Support team, are we ready now?
Just a second. We are live in 3, 2, 1. Please start. So we are live.
So hello, good evening, everyone. It's a great pleasure to welcome you all for this Oncology Up to Date 2022. These are excellent topics which have been designed by the scientific committee, and it's a pleasure to invite and welcome Dr. Akash Tiwari, Consultant Medical Oncology at Shelby Hospital, Indore. So good evening, Dr. Akash. We request you to take the proceedings further and set the ball rolling, please. Over to you, sir.
Hi, good evening, everyone. I know 6:30 is an early start. A lot of our friends would be in OPD. But thanks for joining in. At the onset, I like to invite our senior and very dear friend, Dr. Rakesh Taran sir, for his opening remarks. And then we can start with the academic feast. Thank you. Sir, the stage is yours.
Thank you, Akash. Thanks a lot for giving me the opportunity. And it's always wonderful to interact with all of my favorite colleagues and dear friends, including Akash and everyone. And this is going to be a wonderful session. I had gone through all the topics and they are very good. So back to the organizers for the start.
So the first session that we have is on breast cancer updates. And the first talk would be by Dr. Praveen Paliwal, sir. Dr. Praveen Paliwal, sir, is a consultant medical oncologist at Bansal Hospitals at Bhopal. And he'll be giving his talk on the newer treatment approaches in HER2-positive metastatic breast cancer. Dr. Praveen Paliwal, sir.
So, hi everyone. Good evening, everyone. So, are my slides visible?
Yes.
Okay.
Yes, sir.
So, good evening, everyone. So, I thank the organization, especially Dr. Akash Tiwari, for giving the opportunity. So, I will be the opening batsman for this program. So, topic I am going to discuss today is the new treatment approaches in the management of HER2-positive metastatic breast cancer. And specifically, I believe talking about the role of pertuzumab in the metastatic breast cancer. As we all know, whenever we see a patient of metastatic breast cancer, we do the testing for after the staging work of ERP or HER2, and based upon we decide the treatment protocol for that patient. And we know when the patient has a HER2 overexpression either by the ISC or by FISH testing, it indicates a bad biology, that aggressive biology, because the HER2 positive is essentially the more disease recurrence, extensive disease burden, short-term survival, rapid tumor development, high nuclear grade, and around 20% in our practice patient are HER2 positive. So HER2 overexpression is essentially the bad biology and the bad outcome before the invent of trastuzumab pertuzumab, and they were need to address this unmet need, how to overcome that bad biology. As we can see here, when there is a HER2 gene amplification, it is associated with the less tumor response to the chemotherapy, and there is a decreased survival with the HER2 amplification also. So the first drug that we have to target the HER2 amplification was back in 2001, I think. So the first drug was trastuzumab that was tested in metastatic breast cancer. The standard of care at that time was chemotherapy. So chemotherapy, there were two group chemotherapy with the plus the trastuzumab, and with the addition of chemotherapy, the response increased from 20 months to 25 months. That was approximately 5 month increase survival, and around hazard ratio of 0.8. So 20% reduction in the risk of death with the addition of trastuzumab. But still, many of these patients, they are not surviving very longer. So the response and duration response were still less that we expected in the stage 4 cancer, and the duration most of the patient, around 50%, they progress within 1 year only. So depth of response was less with the addition of trastuzumab. So there was need to add more or to change more so that we can improve the outcome of this patient. For many years, we have this combination only, the trastuzumab and the with the chemotherapy only. But the scenario changed with the addition of pertuzumab in the metastatic breast cancer. So as of now, although as of today, this slide may look outdated, but maybe 2 years back. So this is the algorithm that we follow for the HER2 positive metastatic breast cancer when we see patient of stage 4 metastatic breast cancer patient. First line treatment, the trastuzumab, pertuzumab, and taxane. When they fail, then the TDM1. Nowadays it will be TDXD, and then third line will be HER2 directed therapy, either lapatinib or trastuzumab with the addition of chemotherapy. If the recurrence is within 6 months only, that be rapid progression, then the pertuzumab is not indicated in that setting with the combination of trastuzumab. Then the first option will be TDM1 or nowadays TDXD. Then the second line HER2 with chemotherapy, and then fourth line HER2 and chemotherapy, either lapatinib with combination with capecitabine or trastuzumab and any other drug if available, like tucatinib and other drug. So what is the role of pertuzumab? Why it is indicated in the first line combination with the addition of trastuzumab in combination chemotherapy? So pertuzumab, as we know, it acts on the HER2 implication, but the domain binding site is different compared to the trastuzumab. The trastuzumab bind to the subdomain 4 near to the juxtamembrane region of the HER2 region, but the pertuzumab bind to the domain 2. So it basically prevents the dimerization of the HER2 with the HER3 and HER4, and so by inhibiting dimerization, it inhibits the downstream signaling. So that basically decrease the cell growth and that causes cell kill the cell. So it was first tested in a phase 3 trial, that is the Cleopatra trial, that is the clinical evaluation of pertuzumab and trastuzumab with taxane. So the trial design was very simple. The patient with HER2 positive metastatic breast cancer were randomized to 1:1 ratio of either placebo with trastuzumab, with chemotherapy given was docetaxel, or with the addition of pertuzumab. The number of cycles the docetaxel were allowed were more than 6 cycles if the patient can tolerate, or if the minimum 6 cycles were allowed. Like the prostate cancer stage 4, if the patient can tolerate 7, 8, 9 cycles, so the patient can go on can take the docetaxel and number of cycles. The primary endpoint was the independent assessed PFS, and the secondary endpoint was investigator assessed PFS, OS, and the overall response rate. So we have seen the result in 2012, 14, 18, and the 8-year update also of this Cleopatra trial. So the first interim analysis came in 2011. So when they report the overall survival, the second result came in 2012 for the OS data, and for February 2014 the final OS came, and in the November 2018 the result were updated for the end of the study analysis. So we will discuss later in the upcoming slide. So what were these results for the Cleopatra trial? So for the first interim analysis, the primary analysis, that was the PFS for the independent assessed PFS, with the addition of pertuzumab, the progression-free survival increased from 12.4 months to 18.5 months. That was the 6-month increase in the PFS with the addition of pertuzumab. The curve starts separating very early, that is the 3 to 4 months only, and they remain separated throughout the course of the trial. The overall survival with the addition of pertuzumab, the PFS was at the first analysis of 56.5 months compared to the control of 48 months. That is the 16-month gain in the overall survival. And the end of the study landmark at the 8th year, that the OS was 37% in the pertuzumab arm with the median follow-up of 19.9 months. What is fascinating is in a stage 4 breast cancer, any stage 4 cancer, we are talking about the OS data of 8 years. That means in the adjuvant setting also, when we see the patient is survived 5 years, we say they are cured. Now here in the stage 4 cancer, there are some around 35% patients, they are still alive at the end of 8 years. That is very remarkable. The benefit is provided by the addition of the pertuzumab, trastuzumab, docetaxel, and the subsequent line, but still in the stage 4, that is very remarkable. the safety profile of the combination of pertuzumab and the trastuzumab, the cardiac safety, they were well maintained at the 8-year follow-up also. So we have a very mature data of 8 years with the addition of with the pertuzumab and trastuzumab, the docetaxel. So in the final overall OS analysis that was done at the 8 year. So with the addition of pertuzumab, there was a 15.7 month median gain in overall survival with the addition of pertuzumab. Also, for the final PFS analysis that we seen earlier, the first interim analysis, that was 6.3 month gain in the PFS with the addition of the pertuzumab. The hazard ratio 0.68 with the addition of pertuzumab. So these are the survival. So 1 year, almost same comparable, around 90% patient alive at the end of 1 year, and then the difference keep increasing with the longer follow-up, and we can say 5 years, 6 years, 7 and 8 years, 23% in the control arm and 37% in the experimental arm, that is the addition of pertuzumab. And that is despite that the crossover was allowed, that the patient in the control arm who have progressed, they were allowed to take the pertuzumab despite taking the crossover, and despite those patients in the control arm, they were included into the intention to treat analysis. This overall survival advantage remain persistent across a longer follow-up of 8 years. So that we have seen earlier. So 8-year OS 37% versus 23 year. That is the difference of around 15%. That is very remarkable in any cancer, that is stage 4 cancer. Then 15% patients more are alive with the addition of the drug, that is the pertuzumab. So whenever we treat a stage 4 cancer, not only the PFS OS matter, the response rate and the rapidity of response also matter, because the response, rapid the response and the more durable the response, that means the more better the quality of life. So with the addition of pertuzumab, in the control arm, the response rate was 70%, and with the addition of pertuzumab, it increased to 80%. It was 10% increase in the response rate. So that means the more better quality of life for the patient. And the duration of response, that means how long the drug is working, that was also better with the addition of pertuzumab in the first line. So it was a gain of 7.7 months with the addition of pertuzumab with the duration of response. So there were some subgroup analysis, although they were not pre-specified in the clinical trial. So, but they were exploratory. But say the analysis was done based on the hormone status, the prior treatment that they have taken at the trastuzumab in the adjuvant neoadjuvant setting, the site of metastasis, CNS disease, or the age subgroup. So the hormonal status, because because many of these patients, they are ER/PR, the HER2, so that is the HR positive. So on the OS and the PS, so either they are ER/PR positive or negative. So the OS benefit was seen, and the OS benefit was seen irrespective of they were ER/PR positive or negative. The hazard ratio almost 0.7, 0.6, 0.73, 0.64. That means the HR receptor status doesn't matter with the addition of pertuzumab. Both groups benefit with the addition of pertuzumab. And although that is somewhat surprising that we don't do practice, that is the non-concurrent hormone therapy was allowed before the disease progression. Many of the time what we see, and most of what we follow is, whenever we finish, the patient finish the chemotherapy, the docetaxel, and when they go on to maintenance pertuzumab, we add the hormone therapy. But in this clinical trial, that was not added till the time the disease has progressed. So in the treatment the EBC, so early breast cancer, the patient has received without neoadjuvant chemotherapy, the hazard ratio 0.66. Even if they have received the neoadjuvant therapy earlier, it was 0.66. And patient with the neoadjuvant therapy with the trastuzumab, so it was still all this subgroup, they benefit from the addition of the pertuzumab. Same with the PFS, either they receive the trastuzumab in the neoadjuvant setting or adjuvant setting, they still benefit from the hazard ratio 0.6 with the addition of pertuzumab. So as we all know, during a course of the HER2 positive, many of these patients they do develop the CNS metastasis, and with the addition of pertuzumab, So median time to progression of CNS metastasis was less with the addition of pertuzumab compared to the experimental arm, control arm, sorry. And sometime what happen is, and we have seen with the many of the other cancer. So when the age group is like more than 65 or 70, so those patients, they don't get benefit from the whatever the new drug has been tested. So but in this Cleopatra trial, either the age was less than 65 year or more than 65 year, both these patient group, they get benefit from the with the addition of pertuzumab. So more than 65 response rate even better with the pertuzumab, 84% with the 70 compared to 70%, less than 65, 60 versus 79. So that means the both the response rate was same irrespective of the age, or less than 65, more than 65. So Perjeta, that with the addition of pertuzumab in the first line, it is a when we add the new drug, so we have the option how to adjust the dose of the pertuzumab, what will the new increase new side effect, and how, because the pertuzumab, like it is like a trastuzumab target the HER2, there may be more cardiac safety. So what were the impact of these three outcome in this clinical trial? So the long-term safety and cardiac safety profile of with the addition of pertuzumab were maintaining the overall and crossover population. Overall means the experimental arm, and crossover means the patient who has taken the pertuzumab after the progression in the control arm. So with the addition of the pertuzumab, diarrhea is more compared to the control arm. As we all know, the diarrhea ground grade 3 was 5% in the HT arm and the around 10% in the pertuzumab arm. But in our clinical practice, we know that it can be managed with the antidiarrheal drug like the loperamide. RAS slightly more with the addition of pertuzumab, 1.3 grade 3 versus 3.74. The liver, the LV dysfunction based upon the 2D echo and any other modality, it was more or less same. So the grade, so it was same in the both the arm. Grade 3, 3.3 versus even it was less with the addition of pertuzumab. So cardiac safety more or less same, but the diarrhea and RAS were more with the addition of pertuzumab. And so, yeah, and when we add because the chemotherapy arm, so number of cycle of docetaxel taken was similar in the both the arm, 8 cycle. Dose intensity was more or less same, and dose escalation in our clinical practice, we normally don't start with rarely we go up to 100 mg per meter square. So generally we start with 75 and maybe we have to decrease to 65, but in this trial, so around 15% patient can go up to the 100 mg per meter square. So with the addition of docetaxel, because we know there will be alopecia, diarrhea, myalgia, nausea. So, but these side effect with the addition of the pertuzumab were more or less similar in both the. Also so with the addition of pertuzumab, the age, because when the age is more than 65, the older age patient, they have the more. They made a lot more serious side effect, grade 3 and grade 4. But the common side effect that we see with the addition of docetaxel and with the addition of pertuzumab, the alopecia, diarrhea, the neutropenia, nausea, and the phenylneutropenia, they were more or less similar in both the arm. So these are the grade 3 and 4 side effect. They were similar in both the arm. So the cardiac safety wise, there is apprehension, because when we add the second drug that can decrease the left ventricle dysfunction, that can cause left LV dysfunction. So with the addition of pertuzumab, so there were no cardiac safety signal. So so basically, so it was 3 point grade. So the patient with reduction in LVF by more than 10% and less than from the baseline, and into less than 50% was 3.3 in the control arm. Compared to the pertuzumab, it was only the 1.5%. So basically, the addition of pertuzumab doesn't cause the new cardiac signal, doesn't cause the decrease in LV ejection fraction. And as we all know, so these decrease in LV ejection fraction, they are reversible. So most of the patients, like the 90%, of the patient recover to normal LVF after stopping the pertuzumab and the trastuzumab. So basically, all the major body all over the world, either the NCM, NASCO, the ESMO, they recommend the pertuzumab in the first line in the HER2 positive metastatic breast cancer. And we all know the ESMO, basically they have most stringent criteria to approve a drug in their setting. So they analyze many factors like the cost effectiveness, the cost, the how much burden it costs to their healthcare system. So they have given a rating of the 4, the maximum is 5. So 4 rating means that means they highly recommend this new standard of care to the effective treatment. So dose wise, we know, so the dose of flat dose is not based upon the per kilogram dose like the trastuzumab. So pertuzumab, the flat loading dose is 840 mg, and then you can, and then the subsequent dose will be to 420 mg for the in combination with the trastuzumab. And whenever there is a more than 6 week gap is there, maybe mostly because of the decrease in LV injection fraction, then you have to again give the loading dose and then continue with the maintenance dose. If the gap is less than 6 weeks, you can still continue with the loading maintenance dose of 420 mg. Like this, it is same with the trastuzumab, and the same with the pertuzumab. For the trastuzumab also, if the gap is more than 6 weeks, we have to give the loading dose of 8 mg per kg. And the cardiac monitoring safety, because every 3 months we have to do the 2D echo, and these are guidelines similar for the trastuzumab when we have to stop the pertuzumab. That means there is a fall ejection fraction less than decrease to 50% with a fall of more than 10% from the baseline. Then we have to stop the drug. Then when and do the monitoring subsequently, and when it recover, we can again restart the drug. So to summarize, the unprecedented significant OS improvement with the pertuzumab, trastuzumab, docetaxel compared with the docetaxel, trastuzumab, the first line MBC, the observed at the final OS analysis were maintained at more than 8-year follow-up. That means there were consistent benefits seen all over a longer period of 8 months. Median 48.1 OS with the control arm versus the 57.1 month with the experimental arm. There was a 16.3 month gain in the overall survival. And the investigator's PFS effect was maintained with the hazard ratio of 0.65. Safety profile is consistent with all the subgroup, that either the HR positive age less than 60, more than 60, the CNS mets and the other group. The long-term cardiac safety was maintained at the end of study analysis. And the longest follow-up for patient for the first line treatment of HER2 positive metastatic breast cancer, that is a 120-month follow-up now we have with the pertuzumab. And still, I can say in 2022 in the March, the pertuzumab, trastuzumab, docetaxel remain the standard of care for the patients who are not been previously treated with the HER2 positive metastatic breast cancer. Thank you.
Thank you, sir, for a wonderful talk. Sir, it is just strange. We usually use hormonal therapy with the maintenance Perjeta trastuzumab. Do you see a particular reason that it was not used on the trial, or?
So I was going through the method, but I think it was not mentioned. I don't know. So because maybe what was they thinking? So usually we do when we stop the docetaxel, we start on the hormone treatment. So I think that will be logical sense, because we use this in the adjuvant setting. So I think no reason that I can say why it was not used.
Thanks, sir. Thanks for the wonderful talk. The next session is by Dr. Shrikant Tiwari, sir. He's consultant medical oncologist at the Jawaharlal Nehru Cancer Hospital at Bhopal. Dr. Shrikant would be talking on recent developments in management of ER positive and HER2 negative metastatic breast cancer. Sir, this stage is yours.
Okay, good evening, everyone. Am I audible?
Yes, sir, you are audible. Please make it full screen, sir.
Okay, how can I make this screen on the full view?
So at the top, there is the option slideshow.
Okay, now, yeah,
Yes.
it has done.
Yes.
Okay, so thank you, Dr. Praveen, for the wonderful presentation on the recent advancement in HER2 positive metastatic breast cancers. Now, I am going to discuss about the recent development in the management of HR positive and HER2 negative metastatic breast cancer patients. This is the temporal profile of development of hormonal therapy in metastatic breast cancer patients. The first hormonal therapy, that is the tamoxifen, which is ACRM group drugs, it was introduced in 1977. And if you see from 77, there is 2 decades happens to the development of next line of therapy, that is the aromatase inhibitor. And the 3 aromatase inhibitor, that is anastrozole, letrozole, and exemestane, that invented side by side within a period of 2 years. First time in 2002, the first injectable fulvestrant, that is hormone therapy, injectable hormone therapy was developed. And after then, again, there was a gap of around 1 decade till the 2015, when there was the first CDK4/6 inhibitor, that palbociclib, was introduced. It was approved for the treatment of HR positive, HER2 negative breast cancer patients as a first line therapy, along with the aromatase inhibitor. After 2015, in 2017 and 18, another CDK4/6 inhibitor, that is ribociclib and abemaciclib, was also approved for the same indication. The indication of palbociclib, in case of female, the palbociclib is indicated for the treatment of HR positive, HER2 negative, locally advanced and metastatic breast cancer patients, either in combination with aromatase inhibitor or in combination with fulvestrant in those women who have received prior endocrine therapy. In pre or perimenopausal females, the endocrine therapy should be combined with the LHRH agonist. In case of male, the palbociclib is indicated for the treatment of HR positive, HER2 negative advanced breast cancers, along with the aromatase inhibitor as initial endocrine therapy, and along with the fulvestrant in those patients who have received prior endocrine therapy. So now, what are the data says when this CDK4/6 inhibitor are used as a first line or as a subsequent line? So when CDK4/6 inhibitor is used at the first, there are 4 important trials has been done: the Paloma 2, Monarch 3, and Mona Lisa 2 for in the postmenopausal females, and Mona Lisa 7 for the pre and perimenopausal females. And if you see the median PFS in all 4 trials is almost similar. It varies from 25 months to 28 months, with the hazard ratios also almost equals 0.5 in all these 4 trials. The overall survival data is not matured in 3 trials except this Mona Lisa 7, where the overall survival data matured and say that the overall survival is around 60 months versus 48 months ribociclib versus placebo. Now, the main focus, the palbociclib, when it is used as a the first line therapy, what the global phase 3 trial says. The Paloma 2 trial, it was the phase 3 multicentric study. It was the inclusion criteria was the patients included postmenopausal females, ER positive, HER2 negative breast cancer patients. No prior systemic treatment for the advanced disease has been taken. Those patients who have taken adjuvant chemotherapy and hormone therapy as an adjuvant setting, and in whom the disease-free interval were more than 12 months, were included in the study. The randomization was done 2:1. In palbociclib arm, the dose was 125 milligram once daily plus letrozole, and in the second arm there was the placebo plus letrozole. The primary endpoint of this study was the investigator assessed PFS, and secondary endpoint was the pharmacokinetics, safety profile, and patient reported outcome. On the median follow-up of 37 months, in palbociclib arm, the median PFS was around 28 months, versus in placebo arm, the median PFS was around 15 months. So the median PFS is almost double in case of palbociclib plus letrozole arm in compared to the placebo arm. On subgroup analysis, if you see this the forest plot, the benefit is seen across all subgroup of patient, irrespective of age, irrespective of whether the disease is visceral mets or non-visceral mets, or is there only bony mets. whether the treatment-free interval was less than 12 months or more than 12 months or more than 2 years or 5 years. The benefit was seen in across all subgroup of patients in the favor of palbociclib plus letrozole arm. So the conclusion of this Palomar-2 trial, so after 37 months of median follow-up, the palbociclib plus letrozole consistently saw improvement in median PFS versus the placebo plus letrozole in the overall population, that is 27.6 versus 14.5 months. And across all the subgroup of patients, the palbociclib was well tolerated, with most common adverse effects being neutropenia and leukopenia. However, the overall incidence of this neutropenic fever was very low. It was 2%. And even with the long-term follow-up, the safety profile remained consistent with the previous observation, and no new safety signals were observed with the palbociclib plus letrozole combination. The palbociclib plus letrozole, so it should be regarded as an important first-line treatment option in HR-positive, HER2-negative advanced breast cancer patients. Now, what data says when we are using this CDK4/6 inhibitor in the second line? Again, there was multiple trials for this palbociclib, ribociclib, and abemaciclib. The Palomar-3 trial for palbociclib, Monarch-2 for this abemaciclib, and Monalisa-3 for ribociclib. The median PFS in these trials, in Palomar-3 trials, the median PFS was around 11 months versus 4.6 months. So the median PFS, when we are using palbociclib as a second line, the median PFS is almost double if you compare with the placebo arm. In Monarch-2 trials, the median PFS is around 17 months versus 9.3 months, whereas in Monalisa-3 trials, the median PFS is 20.6 months versus 12.8 months. The overall survival data shows in Palomar-3 trials, it was around 35 months versus 28 months. In Monarch-3, it is much better, the 47 months versus 37 months. And in Monalisa-3, still the overall survival data has not reached versus the 40 months. But the one thing which is important to see in these 3 trials, that in Monarch-2 trial and Monalisa-3 trials, they have used only those patients who have not taken any prior chemotherapy, and they have used only one line of prior endocrine therapy. Whereas in Palomar-3 trials, the patients which are included in the study, they've taken many number of prior endocrine therapy, and they've also taken prior chemotherapy. So definitely the patient performance status were not as good as if you compared with the patients which are included in Monarch-3 and Monalisa-3 trial. Now, palbociclib data in second lines. The trial was the Palomar-3. Again, it was a phase 3 double-blind multicentric study. Randomization was done is 2:1. And patients included in this trial were both premenopausal, perimenopausal, as well as the postmenopausal. Those patients who progress on prior endocrine therapy, and those patients who have also taken prior at least one chemotherapy are included in the study. The palbociclib given was again 125 milligram once daily plus fulvestrant, and in second arm the placebo plus fulvestrant. The primary endpoint of the study was the PFS, and secondary endpoint was overall response rate, overall survival, duration of response, as well as the safety and tolerability. This is the updated overall survival analysis. On median follow-up of around 73.3 months, that means on approximately 5 years on median follow-up, when we are using the palbociclib as a second line therapy, the median overall survival is around 34 months. And if you see the median OS in this placebo arm, it is around 28 months. So almost the overall survival is almost double in palbociclib plus fulvestrant arm after 5-year follow-up period. The overall survival in this study trials has also shown that the overall survival is also depend upon the sensitivity to prior endocrine therapy. So in those patients who are sensitive to prior endocrine therapy, there was seen that absolute improvement in median overall survival in palbociclib arm versus the placebo arm was around 10 months. So those patients who have previously responded well with the endocrine therapy, it is chance that they respond well with this palbociclib. This is the updated PFS in Palomar-3 trials. The median PFS was around 11 months versus 4.6 months in placebo arm. So the median PFS is also almost 3 times higher in palbociclib plus fulvestrant arm versus placebo plus fulvestrant arm. On subgroup analysis on the basis of menopausal status in Palomar 3 trials, on subgroup analysis in whether the patient is premenopausal, perimenopausal, or postmenopausal, the median PFS is almost same. It is 9.5 months in premenopausal patients versus 9.9 months in postmenopausal patients. And similar in the placebo arm also, the data is 5.6 months and 3.9 months. So there is no much difference in the efficacy whether the patient is premenopausal or postmenopausal. So conclusion of this Palomar 3 trials, the palbociclib when combined with fulvestrant, it significantly improved the median PFS compared with the placebo plus fulvestrant as a therapy in those patients who are HR positive and HER2 negative advanced breast cancers. A median PFS of around 11.2 months seen with the palbociclib plus fulvestrant compared to the placebo arm, whereas the median PFS is around 4.6 months. The palbociclib was well tolerated with most common adverse effect in neutropenia and leukopenia, what we have seen in the Palomar 2 trial also. And palbociclib in combination with fulvestrant is an effective treatment option those women whose cancer has progressed on prior endocrine therapy. The absolute difference in the PFS gain is around 6.6 months with the palbociclib plus fulvestrant, which was maintained for the overall survival. A 10-month improvement in overall survival was also observed in those patients who has shown the prior sensitivity to endocrine therapy. Safety data of the CDK4/6 inhibitors. We know that there are 3 CDK4/6 inhibitors, the palbociclib, ribociclib, and abemaciclib. And the most common adverse effects which is seen with the palbociclib is mainly hematological toxicity. There's the neutropenia, leukopenia, sometimes thrombocytopenia is seen. With ribociclib, apart from the same hematological toxicity, there is the chance of the QT prolongations. So we have to do ECG on the regular basis. The chances of hepatotoxicity and GI disturbance is also there. In abemaciclib, apart from this hematological toxicity, the GI disturbance is the most important, along with the hepatotoxicity. And one unique adverse effect which is seen with the abemaciclib, which is not seen in the other CDK4/6 inhibitor, is the chances of venous thromboembolism. So this is the comparative toxicity of this CDK4/6 inhibitor. Although the chances of grade 4 toxicity is not seen or rarely seen in any patients, but the chances of grade 3 hematological toxicity is seen in the palbociclib, ribociclib, as well as the abemaciclib also. The hematological toxicity is least seen in abemaciclib. It's mostly seen in the palbociclib and ribociclib. But the GI toxicity, if you see the GI toxicity, is maximally seen in the abemaciclib. It is not seen in the palbociclib and very less in ribociclib. Similarly, the derangement of the liver function test is also more common in ribociclib and abemaciclib in compared with the palbociclib. So if you analyze all the adverse effect profile, the palbociclib is the most well tolerable drug among all these CDK4/6 inhibitors.
Sorry for intervening. You have 4 minutes left to conclude.
Sorry?
So you have 4 minutes left to conclude.
Okay. So monitoring, what we done in palbociclib, usually we do with CBC because the hematological toxicity is the only toxicity seen with the palbociclib. Whereas in ribociclib, we have to do the CBC testing along with the ECG testing, electrolytes profiling, as well as the liver function test also we have to do. Again, with the abemaciclib, apart from the hematological profile, we have to check regularly this electrolyte profile as well as the liver function test also. So safety data of the palbociclibs. If you see the safety data, if the patient has developed grade 3 or sometimes grade 4 hematological toxicity, so we can have options of reducing the dose from 125 milligram to 100 milligram, and then the second dose reductions to 75 milligram. And if you see the landmark analysis at 3, 6, and 9 months, there is no much difference in the PFS was seen, whether the patient is taking 125 milligram or 100 milligram or 75 milligram. So similarly, there was no difference in seen whether in PFS as well as the overall survival. So if the patient is not tolerating palbociclib, we can reduce the dose. It will not affect the progression-free survival or overall survival. Now, what are the real-world evidence of these CDK4/6 inhibitors? These are the systemic literature review of the real world evidence, and they have chosen certain parameters, the effectiveness of drugs, the treatment pattern, the safety profiles. They have taken economic outcome, the quality of life index, and the chances of the QT risk prolongation. And if you see this pie chart, the most the economical and the most tolerable drug, if you see, the palbociclib has the better edge if you compare with the other two CDK4/6 inhibitors. Now, what are the real world evidence of the palbociclibs? This is the Flatron data. I'm not going to detail about the Flatron network. What this Flatron data says, the real world PFS. According to this Flatron evidence, the real world evidence, they have taken two parameters. The one is this stabilized inverse probability treatment weighing, and second is the PSM, that is the propensity score matching. And on this basis, they have seen this the real world median real world PFS as well as the overall survival. So according to this data, the this median PFS in palbociclib arm is around 20 months, where in placebo arm it is around 11.9 months. And in PSM profile, the palbociclib, so again the median PFS in real world is around 20.2 months versus 11.9 months in placebo arm. Similarly, this overall survival data, again, the overall survival is still not reached in palbociclib arm, whereas the median overall survival in letrozole only arm is only 43.1 months. So in conclusion, in the real world settings, the first line palbociclib plus letrozole is more effective than letrozole alone in a heterogeneous population and among the various patient subgroup. Although the median OS was reached in the letrozole alone group, the significant censoring in the OS analysis highlights the need for subsequent evaluation and longer follow-up is required. And these data complement the superior clinical efficacy observed when the CDK4/6 inhibitors were randomized in the clinical trials. The another real-world data, I'm not going detail of this study background. And if you see this real-world best tumor response, those patients who are treated in the first line setting with the palbociclib plus letrozole, they are associated with increased likelihood of tumor response compared to those patients who are taken treated with the letrozole alone. A generally consistent benefit of palbociclib plus letrozole versus letrozole alone was seen across all the subgroup of patients, whether the patient is having visceral disease or only bone metastasis, with no significant interactions demonstrated in any of the subgroup evaluated. The overall survival among the patients with one or more tumor response assessment, among those patients with one or more tumor response assessment, the treatment with the palbociclib plus letrozole was associated with a significant longer median real-world overall survival compared to the letrozole alone. Among those patients with one or more tumor response assessment, treatment with the palbociclib plus letrozole was associated with a significant longer median real-world progression-free survival versus the letrozole alone. So in conclusion, so finding from these studies, the complement the data from the randomized clinical study, those show the significant efficacy of palbociclib plus letrozole versus letrozole alone. The another study was the IRIS study. And what this study, it was a retrospective medical chart review study, which analyzed the palbociclib as a first-line endocrine therapy in HR-positive, HER2-negative breast cancer patients. And if you see the result of this, the IRIS study, the PFS and OS, if you see at 12 month and 24 month in across all the globe, with the US, Europe, Canada, Argentina, the PFS and OS rate is almost similar in all subgroup of patients and all ethnic group of patients. So the conclusion of this IRIS study is said that the PFS and OS rate in the patient treated with the palbociclib as initial endocrine therapy at 12 months was more than 82%, and it was more than 95% respectively across all the region. The PFS and OS rate in the patients treated with the palbociclib plus fulvestrant at 12 months was more than 80% and more than 95% respectively across all the region. Medline study, I'm skipping this study. It's the same things what they are saying. Treatment, the treatment satisfaction survey. What treatment satisfaction survey of the palbociclib in real world evidence says? The real world evidence says that the 92.2% the patients reported that the side effects were as expected or even better than expected. Most patients across all the 6 countries felt that their treatment would help them to return to their normal life, and nearly all patients felt that the medication benefit had met or exceed their expectation. The Indian data, the data was published by the RGCI New Delhi of palbociclib, use of palbociclib, and the result of this data says that the median PFS is around 20.2 months. When it is used as the second line, the median PFS is around 12 months. The overall response rate was 80% when the palbociclib is used as a first line, and when it is used as a second line, the median PFS is around 40. This overall response rate was around 48%. The toxicity: 10% of patients had grade 3/4 adverse events, and 20% of patients had neutropenia grade 3/4, while no patients had developed any febrile neutropenia. So the conclusion of that study says that the present real-world data of palbociclib used in Indian population suggests the similar effectiveness to previously published real-world evidence, and it is the standard of care as a first-line first-line therapy in metastatic breast cancer who are HR positive and HER2 negative, and also as a second-line therapy. So this is the another data from Indian institutes, that is the Cancer Institute Chennai, and these data also say, if you see the median follow-up of 13-month periods, the median PFS when it is used as a first line, the median PFS is around 18 months. The median overall survival has not reached. At 1 year PFS is around 73.3 months, and 1 year overall survival is around 90%. So in conclusions, complete response was seen in 4 patients, and none of them has progressed at the time of the follow-up. 24% of patients required dose reductions due to the fatigue and mucositis. However, none of them required drug discontinuation. Had an unusual number of patients with the brain mets who achieve a complete metabolic remission with the letrozole plus palbociclib, and the median PFS in this study was 18 months if you compare with the PALOMA-2 trial, where it was around 25 months. So this reflects that the fact that the real world outcome is usually inferior to the reported in the clinical trials. So the reason could be due to the inclusion of all these all-comers, decreased compliance with the drug intake, and the shorter follow-up. So these saw that how the data differs when we compared with the trial data and the real world data. So now I'm going to conclude the session. So had palbociclib changed the treatment paradigm? Yes, the changing treatment paradigms prior to early 2015, there was no new treatment options for the advanced or metastatic breast cancer patients had been introduced since aromatase inhibitor for over a decade. Little was known about the patient's experience and the satisfaction with CDK4/6 combination treatment at the post-approval in real-world setting. When this palbociclib was approved, so many clinicians like us also hesitate to start with the treatment because we don't know how the patient will respond. So what does the data tell us? The data tell us that the palbociclib plus letrozole in the first-line metastatic breast cancer has shown a median PFS of over 2 years. The real-world data complement the superior clinical efficacy observed in randomized clinical trial and support the use of palbociclib in combination with aromatase inhibitor as a standard of care in the first-line setting, or along with the fulvestrant as in the second-line therapy. Quality of life is maintained even with the longer treatment duration, with high patient treatment satisfaction score with both palbociclib combination, whether it is with aromatase inhibitor or with the fulvestrant. Thank you.
Thank you, Shrikant sir, for the wonderful talk. The next session that we have is actually almost linked to the talk that you have already given. And this is a panel discussion on living longer and living well, now a reality in patients with hormone receptor HER2 negative advanced breast cancers. The panelists with me are actually people that we usually meet in private on spirited discussions. Here it will be less of spirit, more of talks. So Dr. Anup Mantri is consultant medical oncologist in the Mantri Cancer Care Center at Indore. Dr. Deepak Dabkara sir is senior consultant and head medical oncologist at CHL Hospital. Dr. Rajesh sir is consultant medical oncology at Chohetram Hospital currently. And Dr. Vikas Asate sir is associate professor, Department of Medical Oncology at SAIMS. Dr. Suneet Lokwani sir is presently in my sister concern at Jabalpur, Shalby Hospitals at the post of consultant hematologist and medical oncologist. So what we do is discuss shortly are the slides visible?
Yes, sir.
Hi, Suneet sir, you have a wonderful background again.
Thank you. Thanks a lot.
The first and the interesting thing is, as was mentioned earlier also, that the treatment paradigm of a hormone positive, HER2 negative advanced breast cancer has changed. We have Dr. Deepak Dabkara sir with us, and I'd request sir to actually throw in some light that during his treatment course, how has this therapeutic option evolved and what changes had it shown, and how easy or difficult was it to involve in practice a CDK4/6 inhibitor at that time?
So the treatment which was there was letrozole initially and fulvestrant. This was before the CDK4/6 inhibitors came into picture, and after that palbociclib was the first molecule. After that ribociclib and abemaciclib came, and means as per the results of these various trials, we see that there is a significant advantage in PFS, at least doubling of PFS in most of the trials. And the ribociclib also shows overall survival advantage both in premenopausal, postmenopausal patients. And toxicity-wise, the toxicity are very less, well tolerated, and rarely we see that a patient has to stop ribociclib or palbociclib because of severe toxicity. So things have changed, and in second line also after letrozole or CDK4 with letrozole, we also have second line treatment abemaciclib. I have not used in much patients, but things have changed in last 5 to 10 years.
Dr. Vikas Asati sir is here with us, and to admit honestly, he's seeing a very wide variety of patients in his practice, from patients with a poor background in SAIMS to people who are fairly affordable at Chohetram. So, sir, how easy is the acceptance of these drugs in practice currently? As in, what proportion of the patients take it upfront or subsequently in your practice?
So thank you, Dr. Akash, for giving this opportunity. So answer your question that yes, I have a patients like who are like to start with, they start on letrozole. And to be very frank, hardly 10 to 20% of my patients can afford either of the CDK4/6 inhibitor. So 70 to 80% patients are still on either on AI or tamoxifen. And you know that the PFS is definitely better when you add CDK4/6 inhibitor. But even single agent letrozole, or if patient is premenopausal, then ovarian suppression plus letrozole, I think those are also a very good options. But yes, we know that the mechanism of resistance will develop very soon as compared to the patient when someone is taking CDK4/6 inhibitor. So yes, we have OS data also in the first line, second line setting, that they are not only increasing the PFS, they are also going to increase the survival of the patients. But you know, I think the best, most important toxicity that we all are facing, including our patient, is the financial toxicity. Both the drugs, either letrozole or any other AI, plus any of the CDK4/6 inhibitor except Abiva, which has diarrhea. I have never used that drug. Either you take Pelvo or Ribo, both are like wonderful drugs, effective drugs, and the toxicity is the paper toxicity. You will have neutropenia on your report. So I think that's all from my side.
So we know that the therapeutic options, as was mentioned, has evolved rapidly in hormone positive, HER2 negative breast cancer, from being only fulvestrant and AIs and tamoxifen for a large period of time. And to a large extent, as Dr. Asati sir was mentioning, still because of the cost issues, to an addition of CDK4/6 inhibitor, which has given a substantial improvement in the PFS, improved quality of life, and certain drugs, even overall survival. So currently, CDK4/6 inhibitors and its combination with ET are driving better patient outcomes, undoubtedly, with better PFSs and better outcomes for both premenopausal as well as postmenopausal women. So premenopausal women, we know that by NCCN, the standard of care remains an ovarian ablation plus ET plus minus a CDK4/6 inhibitor, most pluses than minuses, or a selective ER modulator, a fulvestrant is another option. For a postmenopausal women, an AI plus CDK4/6 inhibitor or a fulvestrant plus CDK4/6 inhibitors for women who are not in visceral crisis are the standard of care. So I'd like to start with Dr. Suneet Lokwani sir, and with a question that we often face in our practice is that what are the treatment goals that we must look at when we are offering these drugs to the patient, and so that it is easier for us to make them understand also why is it beneficial to us, to them. Suneet sir.
Thank you, Akash, for calling me to this panel discussion, and I'm really humbled and obliged by the organizers. And thank you, Akash. And I welcome all my friends, Deepak sir, everybody. Just to begin my answer, before that, I would like to state what Vikas told already when he was telling that financial toxicity is one of the major toxicities we face while prescribing CDK4/6. So, I mean, when we studied CDK4/6 10 years back, we never thought that it will be such a streamlined thing. I mean, I personally didn't think that way. And now when it is in club and combination with one of the drugs which we give for years together, so things have evolved definitely. And when we are not able to give CDK4/6 to our patients, it definitely hurts us that we're not giving proper, complete care. And because we know from the inside, the idea is to prolong the area of OS per se. And when Vikas was telling this, मुझे राहत इंदौरी साहब की 2 लाइनें याद आई कि जरूरी नहीं कि सब कुछ मुकम्मल हो प्यार में, कुछ किस्से अधूरे ही अच्छे.
सही है. कॉलेज की याद आ गई इस बात से.
तो तुम्हारा तो किस्सा मुकम्मल हुआ भाई, तुम्हारे तो बैठता ही नहीं बोल रहा था.
नहीं, फिर से एक बार बोलो. फिर
राहत इंदौरी साहब की 2 लाइनें थी कि जरूरी नहीं कि सब कुछ मुकम्मल हो प्यार में,
वही सब
कुछ किस्से कुछ किस्से अधूरे ही अच्छे. So please pardon me, Deepak sir, if I'm going off track. And coming back to what Akash asked to me per se, I think so. If you consider the treatment goal part here, expanding the OS horizon would be the primary area where I would be focusing in both the subsets, and that would definitely guide me. Now, see, premenopausal young females, they are definitely one of the high risk strata or high risk category. So special attention is needed as part of the ovarian suppression and ablation is carried out in that segment. But certainly the OS part expanding and the treatment goal from the context of the disease per se remains the same. That is what I would like to state.
Great. So I was pointing out that the treatment goal predominantly would be a better response, a longer outcome in both premenopausal as well as postmenopausal women. There are certain typical challenges.
आकाश, ऐसा है कि अगर आप मीठा खाने जा रहे हैं तो मीठे में क्या खाएंगे सर? हम पान खाएंगे, तो पान के साथ हमारे को क्या गुलकंद भी चाहिए, पान के साथ हमें टूटी फ्रूटी भी चाहिए. So deeper response, longer response, improved QL, these are a clubbed part of the whole spectrum. Actually.
Whole spectrum, definitely. So there's this interesting thought that we had in our minds is that when a lady, say a 60-year-old, 56, 70-year-old lady with metastatic CA breast, the decisions are easier to put them on endocrine therapy and otherwise. So I'd like to put this to Rajesh sir, and there are 2 questions in this part. One key, when these patients with young CA breasts that come to us, women with 37-year-old, 30-year-old, 35 years old, who have metastatic disease. They have, some of them may have visceral diseases also, and they're hormone positive. Some of them strongly hormone positive. Some of them are weak hormone positive, say 6/8, the 5/8s, or 6/7/8s. How do you decide then, sir, to either start them on hormonal therapy, what agent to use, and well, how do you go about the treatment here? So, Rajesh sir.
Akash, if first of all, premenopause, am I audible?
Yes, sir. Yes, sir. You are.
So first of all, these premenopausal ladies, these ladies usually they have high grade tumor. Chance of ER/PR positivity is less compared to the elderly ladies. And in all those ladies who are ER/PR positive, I prefer to go with CDK4/6 inhibitor along with letrozole with ovarian suppression. If at all it is, if patient is affordable, and if patient is not affordable, then again ovarian suppression with letrozole. I prefer this regimen compared to tamoxifen, and these patients have more of psychological problems and they usually, since I have said that the disease biology is not that good as postmenopausal lady, so again there will be quality of life will be quality of life is poorer compared to the postmenopausal ladies in premenopausal ladies.
Great. I like to present this question probably to Dr. Vikas. So, sir, we had this patient, oligometastatic CA breast, 38-year-old female, 6/8 progesterone, 2 meds only. Is it better to treat them with, say, a ribociclib ovarian suppression plus letrozole, or to treat them with a curative intent? So, how do you go about it, sir?
So basically, I would like to know where are the oligometastases are. They are in the bone,
humerus, and one in D10 vertebra.
So both are bony metastases.
Yeah.
So I think in all such cases, what I do, I start with neoadjuvant therapy, and then I repeat I do the response assessment, and if they are responding, I can treat. I have treated few of the oligometastatic diseases, may not be with ER/PR positive, but especially in HER2 positive diseases, where I have tried neoadjuvant chemotherapy, complete full 8 cycles of chemotherapy, if possible dose dense, and if possible, like we can go ahead with curative intent. I have around 6 to 7 patients where I have tried, and especially in the ER/PR positive, if we can plan the radiation at the bony lesions, oligometastatic, like I would love to do that. So provided the primary should also respond in a manner that radical surgery is possible.
It's possible. So is Anup around? Dr. Anup?
And one thing more I would like to add what Dr. Rajesh told, that in premenopausal females, you are doing ovarian suppression abruptly. Either you do surgery or you do LH-RH agonist, or in whatever you use, we are doing abrupt cutoff of estrogen secretion from the ovary. I think that also caused a lot of suppression and a lot of side effect as compared to the side effect caused by either CDK4/6 or letrozole. So that is also very important. The hot flushes and all the physical and psychological side effect, it's really difficult for at least for initial 2 to 3 months.
So this is question is why is overall survival, and I'll give my take on this question subsequently. Is Anup around?
Yes, sir, I'm there.
Hi, Anup. So why do you think that overall survival is considered an important treatment goal in advanced breast cancer? And I bring this question to you specifically because before this data from Mona Lisa's in survival paradigm, there's a lot of debate that should we use CDK4/6 inhibitors at frontline, or should we use it subsequently post progression on endocrine therapy? So we always knew that these drugs are effective. What changed in your practice with the availability of the survival data of these drugs?
Hello, good evening, sir. First of all, thank you, Novartis, for giving me this opportunity. So, as we have seen this, the progression-free survival was not the definitive criteria for overall survival. So in metastatic setting, we are definitely looking for an overall survival. It is a more important marker as compared to progression-free survival. So for me, in a metastatic setting, I definitely look for overall survival. And as we have seen in all the Mona Lisa trials, there is a clear overall survival seen with the use of ribociclib. So for me, overall survival is a very important.
Sure. So interestingly, Anup, when this data of palbociclib had come, our focus, I remember in a lot of conferences, people would say on the palbos data is that you could use it in second line. Why use it in first line? Because they have the similar overall survivals. And I think with the availability of the survival data here, probably it became easier for us to use the drugs in the first line, where I think they solve the best purposes of both improving the overall survival as well as Sir Sunit sir was mentioning, the gulkans and the tutti fruttis that also improve the quality of life. And I think with the addition of these drugs, it is we can improve both the OS as well as the quality of life. So we have this data from Mona Lisa 7, a phase 3 trial in the pre and the perimenopausal women. It reported the longest ever median OS in this subgroup of 58.7 months, as well as the health HR related quality of life was maintained for a longer period of time as compared to placebo. The median survival was 58.7 months in the intervention arm as compared to 48 months with a hazards ratio of 0.76. That will be around 24% relative risk reduction of mortality. In terms of the quality of life also, the time to deterioration was prolonged in ribociclib as compared to the placebo. So to spin this question to Dr. Dipkara sir. So sir, with 3 drugs available as CDK4/6 inhibitor, what helps you make choice of one over the other in your practice?
So I have not used abemaciclib, but these 3 trials, ribociclib, palbociclib, abemaciclib, they all have shown that there was a significant difference in PFS with all the 3 drugs. And toxicity wise, palbociclib, ribociclib, they are nearly same. There's not much difference. So the only important factor presently is this overall survival data, which shows that in patients with bone only mets, it is about 72 months. With others also, it is nearly 60 months. So I think if you have to choose between palbociclib and ribociclib, this data is important. So I think this is the only thing at present which will make me to choose ribociclib over palbociclib. And abemaciclib data, I am not sure if it has shown a OS advantage or not. But among palbo and ribo, choice will be ribo based on this OS data. Quality of life in both these drugs, palbo and ribo, they are same. They are good.
So, Vikas sir, I came across an interesting set of data. In fact, anecdote, some of my friends from Delhi were quoting. So I asked them in respect, we were discussing in respect of a lady with liver mets, and we were planning to start her on ribociclib plus letrozole. And they told that in their practice, if patients are not affording, they usually start with a dose of 400 mg with ribociclib. And we'll come to this data subsequently, that probably dose reduction does not reduce the outcomes that significantly. So sir, have you ever used this strategy, or do you find it interesting, Vikas sir?
So reduction in the dose, like I have done in few patients, may not be with ribociclib. So I have done for serotinib. So I think Novartis people will not be unhappy. It also belongs to Novartis only. I have done with serotinib. Few of my patients taking only 1 tablet. Fewer patients are taking 2 tablets. I have only 1 patient who is taking 3 tablets. So the target therapy will definitely work even in lower dose also, because the mechanism is entirely different. The same is also true for the PARP inhibitor, rucaparib or olaparib. All patients cannot afford the full dose, so like they are benefiting.
So Yes, sir.
Yes, for even for Rocaparev, like till date, all our my patients are taking full dose. But if someone cannot afford, like I can use it lower dose also, because we have a robust data that even by reducing the dose, it is not hampering the PFS and also the OS in a significant manner.
So, sir, for a long period of time, I thought this 200 mg tablets of ribociclib are helpful because if someone develops a toxicity, we can reduce the dose. But we never had a reason to reduce the dose because of a toxicity. They were very
correct. So that's the reason
but
that
now I realize that the benefit of having a 200 mg tablet is that you can give a cheaper CDK4/6 inhibitor to your patients.
I think the Sunesh sir want to say something.
Sunit, sir.
This whole practice in Delhi, this whole practice started when ruxolitinib was launched for myelofibrosis. And being a costly molecule, people used to give 5 mg instead of giving the 15 mg despite normal platelet counts and all. And subsequently, this practice has been extrapolated to other drugs as well. And if you can see enzalutamide also comes to 40 mg with the dose of 160. So many other drugs do follow this pattern.
So like I remember none of my like in a whole department we have 4 or 5 patients of myelofibrosis. None of the patient is taking more than 5 milligram.
Yes, that happens. That was very well started off.
No, but in that case, it is less effective. We cannot compare that example because the ribo in that case it is less effective.
Definitely.
But agree. Totally agree. It is less effective. But
if sometimes there is a cost constraint, we may use it.
At the end of the day, that something is better than nothing part wins in most of the decision making parts.
Okay.
That way, people definitely
for
go
targeted therapies.
Yes, especially for targeted therapies.
So ribociclib we know is a potent selective CDK4/6 inhibitor. It is more potent than its competitors Abema and Palbo. Its free drug concentration is also almost 22 times higher. We know that from the subgroup analysis of the data that dose reduction does not compromise the OS benefit of the ribociclib, both in the Mona Lisa 3 as well as the Mona Lisa 7 trial. Of course, these dose reductions were because of toxicity and not for what we were discussing here. Ribociclib,
sorry for intervening, we have 5 minutes left to conclude.
Ribociclib is the only CDK4/6 inhibitor that has overall survival data in all 3 frontline indications, as well as in second line postmenopausal, where it has an overall survival benefit, with Abema probably having a OS benefit in one. Ribociclib is also the only CDK4/6 inhibitor to receive an ESMO MCBS score of 5, which suggests that it is of a proven clinical benefit also to the patient, apart from the statistical significance that it has. So this thought to Dr. Anup. Anup, do you think that, so we know the data, does your practice also is determined by the fact that which inhibitor, CDK4/6 inhibitor inhibits the, improves the OS and which not?
Sir, I think we have data with ribociclib, the only CDK4 inhibitor which has shown improved overall survival in all stratas, and also the side effects in the is much more tolerable as compared to other CDK4 inhibitors. I feel ribociclib is much more tolerable. It has less myelosuppression as compared to the palbociclib, and abemaciclib I have no experience, but definitely before ribociclib during my first years in 2017 I used to use palbociclib a lot, but in last 3-4 years I think more and more doctors and even I have not used palbociclib for a long time, because I feel the dose reduction and toxicity wise going from 600 to 400 milligram is much more comfortable with ribociclib as compared to palbociclib.
So how do you in your practice monitor these patients subsequently? What test you get and what frequency?
So for ribociclib I do ECG for first 2 months, and I think that later on if there is no QT prolongation I don't monitor ECG again, and CBC I do it every month.
Sure. So
CBC and LFT.
So ribociclib we know has the longest reported safety data of any CDK4/6 inhibitors. Its predominantly toxicity is QT prolongation. but it is usually in doses more than or equal to 600 mg that we see. It has demonstrated safety across the 3 Monalisa trials. So like other CDK4/6 inhibitor, is a safe and easily usable drug. So Deepak sir had initially answered this question of how has the paradigm changed. I like to ask him, how has the treatment paradigm changed, particularly with the updated results of the Monalisa trial? So
just now I have answered that with these 3 palbociclib, ribociclib,
and the survival data, as you were mentioning.
Yeah, the survival data, that is the most important factor at present.
I too agree, sir, that it was actually probably it became easier for us to convince patients rather than other. I know that the survival data is also determined by what populations were there. So cross-trial comparison, I'm not sure if you could do or not, but probably it became easier to convince people. So ribociclib also prolongs the time to chemotherapy as well as time to deterioration in the quality of life in patients, and hence addition of a CDK4/6 inhibitors improves both the PFS, quality of life, and some cases overall survival. Hence, whenever it is possible, I think we must add these drugs to the treatment paradigm. Thank you. So the next session is on lung cancer, and Dr. Srinivas sir would be taking this session. He's a consultant medical oncology at Bharat Hospital and Institute of Oncology, Mysore. He'll be talking on experience sharing on durvalumab in ES-SL, small cell lung cancer. Sir.
You cannot start screen share. I think Akash, you have to close it before I share it, I believe.
So you can share your slides.
I have closed it, sir, I guess.
Yeah, now it's showing. Can you see my slides?
Yes, they are visible.
Is it moving?
Yes, it is.
Hi, everyone. Good evening, all. I thank organizers and AstraZeneca for giving me this wonderful opportunity to talk on this topic, experience sharing on durvalumab in extensive stage small cell lung cancer. We all know that small cell lung cancer, extensive stage, especially when we talk about when the patient walk in, we tell that it's a very poor prognostic disease with a few months of survival and all those things. Nothing has changed much in past 20 years when extensive stage small cell lung cancer is concerned. But now we have few data to say, to give some hopes for these patients. I would like to start the discussion with a case. Mr. X, 35-year-old gentleman in June 2020, came with a complaint of change in voice, which slowly progressed to aphonia and dysphonia, with no comorbidities and with a chronic smoking history. Visit to ENT happened, which they said he has a vocal cord palsy, and he underwent CT scan, brain, head and neck, and chest. So on 8th August 2020, there was a small mild enhancing soft tissue with surrounding fibrosis in left apical segment, with multiple enlarged conglomerated necrotic lymph node in left hilar, paratracheal, and paraesophageal region, with the aortopulmonary window forming nodal mass comprising left pulmonary artery. So based on CT scan, patient was started on ATT, which typically happens in most of our city, and we all know patient, whether he has gone to whether he an ENT specialist or a chest physician or a general physician, whenever any lymph node mass, they will not evaluate, even they don't do FNA or a biopsy to see what is the mass, and generally they start ATT, and typically this patient also was started with ATT. Condition got worsened as usual, what we see in all of, I agree, I presume that everybody agree with me that this is the situation which we come across in routine practice, all of us. and the patient had an episode of seizure in September with started on AED, and follow-up MRI brain showed a 2 into 1.9 into 1.7 centimeter sized marginally enhancing interaxial lesion at left temporal lobe with mild surrounding edema without appreciable mass effect, and there were multiple subcentimeter sized lesions in bilateral temporal and frontal parietal occipital lobes. On 17/10/20, there was an SOL in upper lobe with mediastinal extension and encasement of left pulmonary artery with mediastinal lymph nodes and consolidation in left upper lobe. So this is a PET scan. You can see there is an extensive disease involvement of liver, mediastinum, lung, and you can see there is a lesion in the brain as well. So the histopathology showed small cell neuroendocrine carcinoma. PD-L1, the TPS score shows 3 to 4%. So the final diagnosis was extensive stage small cell lung cancer with brain metastasis was made. So brain radiotherapy was done, followed by systemic therapy. Yeah, there are choices of chemotherapy. Generally, in my routine practice, I start with platinum with etoposide. Now we have a data for good data for immunotherapy combining with chemotherapy. There is a data I'm going to show you in the later slides. So this is an article published for treatment of brain metastasis in small cell lung cancer. Decision making among a multidisciplinary panel of European experts. So the key conclusion of the study was, if the patient has asymptomatic, chemotherapy alone is the most commonly recommended first-line treatment. And if the patient is asymptomatic with limited volume of brain metastasis, still a higher preferences for chemotherapy without WBRT. Even in my practice, if the patient is asymptomatic, I generally start with systemic therapy, wait for symptoms, because this is not, we are talking about a limited stage disease, we are talking about extensive stage disease. If the patient becomes symptomatic, of course, I do WBRT followed by chemotherapy as per the recommendation most commonly. And a few centers, they say that symptomatic patients with limited extent of brain metastasis, they say they can even choose a stereotactic radiotherapy as an alternative to whole brain RT. So then this is an NCCN guidelines on brain metastasis in extensive stage small cell lung cancer. If you see the last column, extensive stage with brain metastasis, if the patient is asymptomatic, may administer systemic therapy before brain RT after completion of induction systemic therapy. And if the patient is symptomatic, then of course the whole brain RT before systemic therapy, unless immediate systemic therapy is indicated. So these are the various regimes, multiple regimes which we come across. What you can observe is none of the regimes, none of the chemotherapy regimes, whatever the combination whatsoever, none have crossed a year of median overall survival. This is a really unmet need in extensive stage small cell lung cancer. Generally, a patient who walks in with extensive stage small cell lung cancer, it's not very a great hope we give to the patient. It's always a disappointing thing. We counsel the attenders, a son or a daughter, that your dad or your mom is not going to survive more than a year. That's what we typically say. They initially they respond better. They go, they are very chemosensitive. They respond, but as how fast they respond, they come as soon as that they come back with a recurrence, and that is the second line and onwards. Not a very great thing to do for these patients. So just like any other patient, the patient underwent chemotherapy on 7/11/2020 with chemotherapy with injection etoposide with cisplatin, and radiation therapy was given 30 grain 10 fractions to whole brain with hippocampal sparing, followed by 9 grain bar 3 fractions to gross lesions. So these are the NCCN guideline latest version. The preferred regime like cisplatin and etoposide, and other regimes, as you can see. So after during third cycle of chemotherapy, durvalumab was added. Durvalumab, as per the recommendation, 1500 mg every month. I'll show you the data for that. So when we talk about durvalumab, yes, of course, now the immunotherapy is evolving in lung cancer. It's also evolving in small cell lung cancer. So it's a PD-1, PD-L1 inhibition restores tumor-specific T-cell immunity. Reversal of immune suppression leads to deeper, more durable systemic anti-tumor response. So these are data which I want to show you. Caspian is the first and only approved IO regime in extensive stage small cell lung cancer to allow up to 6 cycles of EP in the control arm and use of cisplatin or carboplatin. I'll show you the difference between the atezolizumab based regimes trial. In Caspian, what they did, they chose newly diagnosed extensive stage small cell lung cancer patients, 800 and odd patients with good performance status, with life expectancy of more than 12 weeks, at least one target lesion by RECIST, and a stratification either cisplatin or carboplatin were allowed. So it was randomized with 1:1:1. First arm Imfinzi, that is durvalumab plus etoposide plus platinum. Investigation choice of cisplatin or carboplatin was allowed in this trial, and followed by Imfinzi 4th weekly until progression as a maintenance. Second arm is only chemotherapy arm with investigator choice of cisplatin or carboplatin, 4 to 6 cycles, and up to 6 cycles it was allowed. Unlike other trials where only the platinum cisplatin was allowed, the carboplatin was not allowed. So this trial was more of like realistic, near to the real world population. And the third arm was Imfinzi plus EP plus investigation agent. The investigation was tremelimumab. Finally, I'll show you that data that the third arm, with or without tremelimumab, the efficacy was similar compared to the first arm. So the primary endpoint was overall survival. The key secondary endpoints was PFS, overall response rate, OS at 18 months, PFS at 6 and 12 months, and health rate and quality of life. So this is what I was alluding to before. IMP 133 was a atezolizumab based trial, and Caspian is a durvalumab based trials. So if you can look at it, the differences carefully, up to 6 cycles of chemo was allowed in control arm in Caspian, whereas it was only 4 cycles in IMP 133 arm. And untreated brain metastasis patients were excluded in IMP 133, and Caspian, those patients were included. And cisplatin or carboplatin both are allowed in Caspian, whereas the cisplatin was, sorry, I did a mistake by saying that cisplatin actually was excluded and carboplatin was allowed in IMP 133. So if you look at these trial design, the Caspian looks like more of realistic and more to the real world population, where definitely patients would be treated with brain metastasis, patients who do come with brain metastasis, and we know that small cell lung cancer patients, they have a very high predilection to have brain metastasis. So this was the, if you look at the study, this is the population what we have in Caspian is more of like closer to the real world population. So the Caspian study inclusion criteria is reflective of real world clinical practice, and as I told you, allowed treatment with either cis or carbo, included patients with either asymptomatic or untreated or treated brain mets, compared against up to 6 cycles of chemo with optional PCI. So durvalumab 1500 mg plus platinum etoposide 3 weekly for 4 cycles in the initial treatment phase, followed by durvalumab 1500 mg 4 weekly until progression as maintenance. As I told you, both the platinums were allowed, and OS was the final primary endpoint. Control arm could receive up to 6 cycles of platinum etoposide, and optional PCI was offered only the control arm in maintenance phase and not during the durvalumab maintenance. So these are OS based on baseline brain metastasis. If you can see the median OS 12 months versus 18.8 months as a hazard ratio of 0.69, and OS without brain metastasis, the median OS of 13 months compared to 10.5 months in chemotherapy arm for the hazard ratio of 0.74. So if you look at that, so durvalumab plus EP consistently improved OS versus EP in patients regardless of the presence of baseline brain metastasis. So both the patient, whether the patient regardless of brain mets, they did better in both the subset. So if you see the progression-free survival at 12 months, 17.9% versus 5.3%, and at 18 months, 13.9% versus 3.4%, and 24 months, 11% versus 2.9% for the hazard ratio of 0.80. So more than 3 times the number of patients were progression-free at 12 months, and nearly 4 times the number of patients who are progression-free at 24 months with Imfinzi plus EP versus EP alone. So this is something very welcoming thing for me, because we have got so many drugs past decade for small cell. None of them did anything better. So this is, I think, for the first time, Caspian showed some hope to the oncophysicians, so that we can give an option. Patients who can afford definitely is a good option to offer. So 9.1% of patients have been on Imfinzi for more than 3 years, and around 10% of patients were continuing treatment in Imfinzi at the 3-year data cutoff. So imagining a 3-year or a 3rd year of patients who are crossing 3rd year is something very welcoming or very happening in a subset of patients. What we are talking about, extensive stage small cell lung cancer patients. I don't think without newer drugs or novel drugs, we will be able to achieve these kind of outcomes. So this is overall survival. If you see, there are more than 3 times the patients alive in Imfinzi plus EP at 36 months. The median overall survival of 12.9 months versus 10.5 months in chemotherapy arm for the hazard ratio of 0.71. So Imfinzi plus EP improved the estimated percentage of patients alive with 3 times more patients alive at 3 years. Clear separation of the curves is sustained with a notable flattening of the curve observed from 27 months onwards, which further supports a sustained long-term OS benefit. So if you see this subgroup analysis, the patients did well for all the subsets, regardless of whether the age more than 65 years or less than 65 years, male, female, with the performance status, smoking history, and brain metastasis. As I told you earlier, regardless of brain mets patient, both the subset did well, and Asian and non-Asians, and region-wise. So all the subgroups did better with Imfinzi plus EP. So once again, I would like to highlight that cisplatin and carboplatin eligible patients were allowed, patients more than 65 years, former and active smokers, all the patients, regardless of brain metastasis, they did better with this drug. So if you can see the overall response rate, Durvalumab plus EP 67.9% versus 57.6%. And the duration of response is also higher, 22.7% versus 6.3% compared to the chemotherapy arm. So even the duration of response was better. So more than 3 times the patients compared to chemotherapy arm, the patients in Durvalumab remained in response at 24 months with Imfinzi plus EP alone. So follow-up PET scan was done for this patient. By the time Jan 11th, 2021, he had received radiotherapy, received chemotherapy 3 cycles and immunotherapy 3 cycles. If you can see, there is a regression of lesions. Then again, patient was continued with the treatment. On 8th April 2021, patient was again reviewed with PET CT scan. By the time he had received chemotherapy 6 cycles and immunotherapy, the Durvalumab of 10 cycles. There was a decrease in size of photopenic area in right parieto-occipital region of the brain, decrease in metabolically inactive minimal soft tissue thickening in AP window, and seen encasing mildly the left pulmonary artery with no metabolically active disease elsewhere. So Imfinzi is the only IO with clinical trial data supporting a 4th weekly maintenance dose administration scheduled for extensive stage small cell lung cancer patients. So if you see the quality of life, that is a discounted incremental Cali and life year gain. So it shows despite long-term uncertainty, the 3-year OS data provides additional confidence in the estimated incremental benefit of Imfinzi plus EP and demonstrates the additional benefit compared to atezolizumab. Treatment with Imfinzi plus EP adds 1.14 life years and 0.84 Cali compared to treatment with EP alone. Additionally, treatment with Imfinzi plus EP adds 0.2 life years and 0.14 Cali compared to treatment in the atezolizumab. So in conclusion, Durvalumab plus EP is a new standard of care in the first-line treatment of extensive stage small cell lung cancer. First-line Durvalumab plus EP has shown sustained improvement in OS compared with a robust control arm that is reflective of a real-world scenario by allowing up to 6 cycles of EP and the use of PCI as compared to the results from the atezolizumab carboplatin interposite study of IMpower 133. The Durvalumab is the only IO that provides flexibility of choosing cisplatin or carboplatin along with etoposide. Benefit with Durvalumab plus EP was observed across all subgroups. We saw that. So even including the brain mets subgroup. So more than 17% of patients on Durvalumab plus EP arm are surviving even after 3 years, showing prolonged survival benefit. This is something really feels that we need to offer the patient. We need to tell the option. We need to share this data with our patients so that they can make a suitable decision. Imfinzi plus EP provided a higher response rate and demonstrated an ongoing response at 2 years and more than 3 times the number of patients compared to chemotherapy arm. The Durvalumab patients did very well. and durvalumab offers convenient once monthly dosing regime in the maintenance phase. Safety findings remains consistent with known safety profile of durvalumab and DP. We know that we have given durvalumab in many of the especially in stage 3 adjuvant durvalumab. We have given patients are able to manage this drug. Now we are familiar with this drug. I think we'll need more and more data to say how much it goes, how much it benefits in a long term. Thank you.
Thank you, Dr. Srinivas, for that wonderful talk. I must say that each time that we hear to this data of Caspian, we realize this point that almost 3 times more people were surviving at 2 years as compared to the control is so much more heartening, especially that people were living up to 3 years too.
Dr. Akash, we have seen patients dying in front of us, small cell lung cancer, so helplessly. We will definitely, before durvalumab, we used to give second line, third line with taxane, irinotecan, carboplatin, lot many drugs, but none of them has helped them greatly till today. So we tend to give, as an oncophysician, when the patient comes with the pain, we try to palliate them with the different lines of therapy, but most of the time, none of the regimes will help much. And I agree with the data. Something has to come up. Something has to be a novel in these patients so that their survival becomes better.
So the next, continuing the same concept, the next talk is by Dr. Praveen Paliwal, sir. And this time it is on the role of dual IO therapy in the treatment of first-line metastatic non-small cell lung cancer. Dr. Praveen, sir, please.
Hi, thank you again. So good evening, everyone again. So I will be speaking about the role of dual IO therapy in the treatment of metastatic non-small cell lung cancer in the first line. So as we all know, whenever you see a patient on stage 4 lung cancer, non-small cell, we do the molecular analysis. When the patient is fit for target therapy, we do the oral TKI, and the other patient get the chemotherapy. But in the era of immunotherapy, we have 2 regimens based on the immunotherapy drug, nivolumab-based drug. So one is, we can say, chemo-free regimen for the patient, and second, we can say chemo-light. So we'll be speaking about the 2 clinical trials that have proven the efficacy of dual IO, that is the nivolumab plus ipilimumab in the non-small cell lung cancer stage 4 patient. So I will be covering this. My talk will include what is the unmet need in the advanced non-small cell lung cancer, the overview of cancer, how the immune cycle operate, and what is the mechanism of action of the immune checkpoint inhibitor. Then I will be discussing about the 2 trials, that is Checkmate 227, the part 1A basically, and the Checkmate 9LA trial, and what is the dosing schedule, how to incorporate these 2 IO drug, and then the last week is to summarize the 2 trials. So we all know, so in India, most of the non-small cell lung cancer patients stays, and they present to us in the advanced stage. So 66, it is more than 66, it will be around 70-80% is stage 4. And the more disheartening is that the survival is very poor. There is around 5% only. So there is a need to improve this outcome of these patients so that they can live longer. So I will be speaking about the breast cancer. We were talking about the 8-year, 9-year survival, that is around 30%, 40% was there. But in the non-small cell lung cancer, still the survival is very poor. And there is a medical need remain high for the effective alternative treatment, that is we are doing other than the chemotherapy, so that we can improve the response, that is the depth and duration, and how we can improve the long-term survival of this patient. So now, so there are 2 regimens based on the immunotherapy drug. The one is the Checkmate 227 trial that was tried in the first-line non-small cell lung cancer patient who were EGFR, ALK, ROS1 wild type, and they were PD-L1 was more than 1%, and they were given the nivolumab plus ipilimumab. And second trial that was done was Checkmate 9LA trial. That was with the 2 cycle of chemotherapy, the IO drug was given in the first-line metastatic non-small cell lung cancer. So we all understand as a medical oncology this slide. So basically, whenever there is a tumor antigen is released, either by the killing of the cancer cell or by the chemotherapy, radiation therapy, target therapy, so that is taken by the macrophage. So there is a T cell priming by the dendritic cell, and then this T cell goes to the lymph node and then goes to the at the tumor site where they kill the tumor cell. But we know the cancer cell are more smart, so they have a CTLA4 on the T cell, so that suppress the T cell priming at the effector phase, and at the tumor level there are two the ligand, the PD1 and the PDL1. PD1 about the tumor and the PDL1 on the T cell. So there is suppression of the T cell at the tumor level. So the cancer cell suppress the immune system. So if we can block these two two sides, that the CTLA4 on the T cell or the PDL1 and PDL1 blockage, so we can overcome that suppression. We can remove that break, and then the immune system may be activated. So basically, so on the dendritic T cell at the priming level, the dendritic T cell which present the adhesion to the T cell. So on the CTLA4 antigen is there. So basically that act as a negative for the dendritic T cell activation. So there is suppression of immune system, and then when we can block this CTLA4 by the drug, that is the ipilimumab. So we activate the T cell. And second, if we block the PD1 or the PDL1 by the either nivolumab or the pembrolizumab, we restore the anti-tumor T cell function. So first trial that was done with the combination was the ipilimumab and the nivolumab combination versus the platinum-based chemotherapy as a first-line treatment for the advanced non-small cell lung cancer. That was the CheckMate 227 part 1 trial. The part 1, basically this trial is a two part. The part 1, that is the PD-L1 more than 1%, and the second group was the part B, that is the PD-L1 less than 1%. Though the key eligible criteria were stage 4 or the recurrent non-small cell lung cancer, they have not received the prior systemic therapy. They were EGFR in the wild type, ECOG more than 0 or the 1, PD-L1 expression more than 1%. And both the histology were included, the squamous versus the non-squamous, and the randomized was 1:1. There were around 800 patients. The one was given the Obrita nivolumab at the dose of 3 mg per kg every 2 weeks, and the ipilimumab 1 mg per kg every 6 weeks. Versus the platinum doublet, that is the pamitrexine in the adenocarcinoma, and the paclitaxel in the squamous group. The treatment was continued until the disease progression, or because of the side effect, the treatment was discontinued. Patients that were excluded were the untreated brain metastasis, the carcinosis meningitis, the activity at autoimmune disease, and the medical condition which required the systemic immunosuppression. They were excluded. So the PD-L1 testing was done by this platform, PD-L1 ISC, so that is standard for the PD-L1 testing. And the median follow-up for this now at present, the median follow-up of the CheckMate 227 is around 54 months, that is around approximately 5 years, and the longest median follow-up of any IO-based combination in this phase 3 trial. So what were the results? So basically, the baseline characteristics were all matched. So mostly patients that we see old age 65 years. The squamous was around 30%, 70% the adenocarcinoma. Mostly were the current smoker or the former smoker around 85%, and the tumor expression that is more than 50%, around 50%, and the 50% 1 to 49, and more than 50%. This trial included only the patient who had the PD-L1 more than 1%. So these were the results. So at the 3-year, the overall survival, 33% patient alive in the IU combination arm compared to the 22%, gain of 9%, and at the 4-year, 29%, 18%. So what we can see, so early in the IO combination arm, there was some rapid progression. So the curve crossover, and they remain separated around the 9 months only. So initially they were rapid progression in the IU combination arm. So because of this factor, that we will be speaking on the another trial, CheckMate Alliance, they include the chemotherapy in the CheckMate 9 trial to prevent that rapid progression. So rapid progression in the IU arm, but after that, when there were the consistent benefit response was seen in the IU combination arm, the hazard ratio is around 0.76 for this in this trial, and the OS data. So based on the histology, both these patient benefit, that is squamous versus the non-squamous, For the non-squamous, 19.4 around 20 months in the non-squamous arm, in the IU combination arm, and the chemo arm around 17 months, that is 2 month gain, that was statistically significant with the hazard ratio of 0.81. For the squamous arm, that was the benefit was less compared to the non-squamous, that is around 14.8 months OS versus 9.2 months, and hazard ratio 0.68. So at the 3 year, 37% versus 28%, and around 9% gain in the overall survival percentage in the IU combination non-squamous, and almost see the gap was more in the squamous arm, around 24 versus 9%, and the 4 year, 20% patients are still alive in the IU combination arm compared to 6% in the squamous histology. So, and the patient who respond to the doublet IU combination arm, that means they who respond at a 6 month, out of them around 70% they were still alive at the 3.5 years. So what we can see, that means the patient who are responded, they are still doing very well. So we can say the earlier we can predict the patient who are responded, so we can say them that they will do good in the long term on. So overall response rates that are typically seen in the chemotherapy around 25-30%, the 30% in this clinical trial versus the 35% in the IU combination arm. Median PFS, we as we see in another trial, maybe the lung cancer, kidney cancer, the PFS is mostly not clinically so significant in the IU combination arm. So it was 5.1 month with the IU arm and 5.6 month. But the 4 year PFS was better in the IU arm, that is the 14% versus the 4%. So the duration of response of combination was maintained at 4 years, that is the 34%. That means the patient who are responding, they're still responding at the 4 year. That is at the 3 year duration of response is still continuing 38% versus the 10 year, and at the 4 year 34% versus the 4 year. So the common side effect that we now, because we all are using the immunotherapy drug for many years, so we can say the most common side effect, they are the reported by the patient are the fatigue or some pyrexia and the edema. The other second most common side effect is skin rash. So that was more in the combination arm compared to the chemotherapy arm, because we don't see the side effect with the chemotherapy. The decreased appetite, that was more common with the immunotherapy arm. The musculoskeletal side effect, they were more with the chemotherapy arm. There are other more common side effect, diarrhea, respiratory, that we all see combination, but there were no new safety signal that we see with the combination arm, more or less that we see in the kidney cancer or with the immunotherapy. So obviously, see the same kind of side effect we seen with the combination arm. And the patient who have discontinued the combination because of the treatment-related adverse effect, they were still getting benefit from the combination immunotherapy. So the overall survival, the overall response rate, and the duration of response in the patient treated with the combination arm, the 4 year OS around 44%, overall response rate 35 as compared to the overall population. Median duration of response 52 months, and the ongoing response, that is more than 3 years after discontinuation, that 50%. So we can say even if the patient, we have to discontinue the drug, the combination of either the ipilimumab or nivolumab or both the drug, those patients are still getting benefit with the combination arm. So based on this trial that we checked 227, so the nivolumab plus ipilimumab was recommended as a first line option for the metastatic non-small lung cancer. It was given a category 1 indication. The patient who are the molecular workup was wild type, and the PD-L1 was more than 1%.
Good evening, sir.
At 4 years, the combination of continue to demonstrate the durable long-term benefit versus chemotherapy in the population of PD-L1 more than 1%. That is 4 OS, 30% versus the 18% with no new safety signal. Among patients with PD-L1 more than 1%, the patient who are responded, that is 70% responded at 6 months, they continue to get benefit from the treatment arm. In the post-hoc analysis, the discontinuation of the combination due to treatment-related adverse effect did not have a negative impact on the long-term benefit seen in the randomized patient. Approximately half of the responder who had a treatment-related adverse effect leading to discontinuation, they maintained the response more than 3 years. And this chemotherapy is an all chemosparing first-line treatment. So because this trial was, because normally we use chemotherapy in some combination with the either the alone or with the immunotherapy. But this trial that show that for some patient who we don't want to use chemotherapy, or with the still even if the patient is fit for chemotherapy, we can use the chemotherapy regimen, that is the combination nivolumab plus ipilimumab. So, but in this the Checkmate 227 trial, these few of the patients, they have a rapid progression, so there was a crossover of both the arm. So the Checkmate 911 in the trial, what they do, so they combine the 2 cycle of chemotherapy with the combination nivolumab plus ipilimumab, for the reason that we can avoid that rapid progression of the disease in few of these patients. So Checkmate 9LA is a phase 3 randomized open label study evaluating the Opdita and the Yervoy, that is ipilimumab plus chemotherapy 2 cycle versus chemo 4 cycle in the first line stage 4 or recurrent non-small cell lung cancer. So after 2 cycle of chemotherapy to the combination arm, that could potentially provide the rapid disease control while building on the durable OS benefit observed with the Opdita plus in Yervoy in the Checkmate 227 trial. So Checkmate 5C8 was a phase 2 trial that showed that this combination can be that was tolerable and that can be tried in the phase 3 trial. So what was the inclusion criteria? So what was this was the clinical trial design. Stage 4 or the recurrent non-small cell lung cancer who have not received the prior systemic therapy, no non-sensitizing EGFR or the ALK alteration, good performance status, that is 0 to 1. Histology wise, squamous versus non-squamous, PD-L1, all the patients were included compared to the 227 trial, that the patient who has the PD-L1 less than 1% or more than 1%, and gender wise, the male versus female. The Opdita was given because the chemotherapy is generally given as a 3 weekly, so the Opdita dose was given 360 mg every 3 weeks. The ipilimumab was given 1 mg per kg every 6 weeks, and the 2 cycle of chemotherapy, that the platinum plus doublet were given. And after completion of 2 cycles, the combination of the IO, that is nivolumab plus ipilimumab, was continued in the experimental arm versus the 4 cycle of chemotherapy plus doublet in the control arm. The same exclusion criteria: patient with the untreated brain metastasis, carcinoma, meningitis, acute autoimmune, and the active autoimmune disease, they were included. So the trial evaluated patient regardless of the patient histology, that is squamous or non-squamous, or the PD-L1 expression. So same demographic characteristic were there that we have seen in the Checkmate 227 trial. So PD-L1 expression, it is more or less same that you will see routine practice, less than 1% 40 and more than 1% 60, and in that also around, we can say 35-30%, that was the 1 to 49 and more than 40%, 50%, sorry. So we have a data of the overall survival of 2 years. So at the 1, so that rapid progression, that rapid crossover was controlled with the addition of 2 cycle of chemotherapy in the Checkmate 9 trial. And the 2 year, the response overall survival 63%, what is 47%. Sorry, 1 year, and the 2 year 38%, what is 26%. And the median was also increased from 15.8 months in the experimental arm versus the 11 months in the control arm. And curve remains separated after initial suppression at the 3 months. So patients who have PD-L1 that is 0 or less than 1%, say, either because normally we see the patients who are PD-L1 positive, they only get benefit chemotherapy. They get benefit from the immunotherapy. But in this trial that we can see, even if the PD-L1 was less than 1%, that is practically 0. So they were also getting the same benefit or even the more benefit with the compared to the PD-L1 more than 1% of the whole population. Median OS around 18 months versus the 10 months in the control arm. At 1 year, 63% patient was still alive compared to 45%, and at 2 year, 37% was the 2 year. So PD-L1 more than 1%, almost same efficacy that we see in the PD-L1 less than 1%. OS 16 months versus the 11 months, and the 1 year and 2 year overall survival comparable. We all know that the patients who are PD-L1 more than 50%, they get benefit from the immunotherapy or the combination immunotherapy. So in that group of patients, the median OS was around 19 months, that is expected, and compared to the chemotherapy, that is 13 months. And the overall response, the overall survival rate also, at 1 year, 70% versus 51%, compared to 45% versus 32% in the control arm. And the curves are widely separated throughout their course. So these are the subgroup analysis. All the group that were randomized, most of the patients they get benefit from the 2 cycle of chemotherapy was with the addition of ipilimumab and nivolumab. Only two subgroup that we can highlight. So as we all know, the patient who are elderly, that is more than 75%, so their hazard ratio cross around 1, and the patient who are never smoker, the hazard ratio is 1. Other group, either they are PD-L1 less than 1%, more than 1%, more than 1 to 49, they get benefit from the this combination. With the liver metastasis, lone liver metastasis, either the perform series 1 or 2, they all get benefit from the this combination arm. And if you talk about the duration of response was longer with the addition of in the experimental arm, that is the chemotherapy with the IO combination. It almost triple in compared to the experimental arm, that is chemo alone arm, that is 52%, 24 at 1 year, and 2 year 12% was 34%, that is almost triple. And in the median duration of response, 13 months was in the experimental arm, and the around 6 months in the chemotherapy arm. So more rapid response, and the depth of response was longer with in the experimental arm. So what are the safety and the profile of the experimental arm? So any treatment adverse effect around 90% in the any grade in the experimental arm, versus grade 3 and grade 4 around 50% in the combination arm, compared to chemotherapy in is 40%. Which lead to discontinuation of the chemotherapy, that is this protocol, that around 18% in the chemo plus IO combination arm, and around 5% in the chemotherapy arm. Leading to all the component, that was around 14% versus the 3%, and serious adverse event more around 26%, and versus the chemotherapy 15%. So we can say the more serious side effect were slightly high in the combination arm, and that lead to the treatment discontinuation was more in the combination arm of the immunotherapy. But because the patient were taking longer duration, because chemotherapy just for the 4 cycle, and the immuno combination in the WIO is for the longer duration, that is for at least maximum 2 years. So we can say there will be more side effect, and the leading to discontinuation at some point of time will be more with the IO arm only.
Sorry for intervening. You have 1 minute left to conclude, please.
And the patient is still, as we see in the 227 trial, the efficacy of the patient who discontinued, so they were responding at 1 year and the 2 year. So these are the common side effects that we see, and at the rate that we see, the most common is skin side effect at the first appear, and the most common. The second is the GI side effect, loose motion basically, and hepatitis, and third is the endocrine, that is the hypothyroidism, and low hepatic with the like the hepatitis, at the around 10 months it appear only. So, but with the more experience that we more use in combination, so these all are kind of, we can say, the manageable side effect. So these are the most common skin side effect, and the second is the endocrine, the third is the GI side effect in the experimental arm. So compared to the chemotherapy, also with the addition of, we know the more the febrile neutropenia, because of inflammation, they are peripheral neuropathy are more in the chemotherapy arm, and with the addition of 2 chemotherapy, this side effect doesn't increase in the combination arm, that is the IO arm. So we can say at 2 years, the overall survival was durable in the combination arm, that is the IO plus chemotherapy arm, the 38% versus this 26%. Benefit was observed across all the case subgroup, irrespective of the PD-L1. There were no new safety signal were observed with this experimental arm of IO plus chemotherapy. And in the post-hoc analysis, the patient who has to discontinue because of either some reason, they still get benefit from the chemotherapy plus IO combination arm. And checkmate 9LA demonstrated that Obrita plus Yerovi with 2 cycle of chemotherapy should be considered as a new first-line treatment for the advanced non-small lung cancer, irrespective of the histologies, irrespective of the PD-L1 expression, and irrespective of the gender. Thank you so much. So these are the dosing schedule. So we use for the this CAM. So Obrita was given 3 mg per kg, that is 360 mg in the 9LA trial, and for the checkmate 227 is 3 mg per kg, and Yerovi, that is the 1 mg per kg only. So thank you.
Hi, so the next talk would be by my very dear friend, Dr. Taha Setjiwala. He's a consultant medical oncology at SRJ Hospital, SRJ CBCC, sorry. The talk is on role of atezolizumab for first-line treatment of metastatic non-small cell lung cancer. Taha, the stage is yours.
Thank you, Dr. Akash. Thank you so much. So I would like to thank you all. Thank you, Rosh, for this opportunity. And should I start sharing? Can you all see my screen? Hello?
Yes, sir. We can see your screen, sir.
Yeah. Yeah, so hi. Without wasting much time, so this is the role of atezolizumab in advanced non-small cell lung cancer in first-line setting. So there are these three trials which I'll be discussing: IMpower 110, IMpower 160, and IMpower 130. I'll skip the introduction part. Let's go on to, yes. So what this slide tells us that in lung cancer, we've seen a lot of success. That is mainly because of the mutations, and that we are able to target them. Now, there are 35% of the patients where mutations are unknown. So immunotherapy plays an important role, especially immuno with chemo plays an important role in these patients. Now, the three trials, 110 is mainly atezolizumab monotherapy versus chemotherapy. IMpower 130 is atezo with chemo versus chemo. And IMpower 150 is whether addition of atezo to the standard of care, Bev with chemo, is it beneficial or not? So I'll come to them individually. Now, IMpower 110, where you see that whether atezolizumab monotherapy is compared to chemotherapy in case of non-small cell lung cancer, both squamous as well as non-squamous. Now, again, phase 3 randomized study where chemotherapy naive patients. So upfront, 2 arms, atezo monotherapy used in 1200 mg, 3 weekly dose versus for non-squamous, they've used PEM carbo-OSIS. For squamous, they've used GEM carbo-OSIS, 4 to 6 cycles, and then maintenance. Now, what this slide tells us that in this study, basically PD-L1 expression. So there are 3 varieties. One are high PD-L1 expression, that is TC3 or IC3, more than 50%. TC2 is kind of, mid range, and TC1 is just more than 1%. So basically all the patients are PD-L1 positive, more than 1%, more than 5%, and more than 50%. So the next slides, we'll be mainly talking about the patients with high PD-L1 expression, that is more than 50%. That is TC3 or IC3. Now, if you talk about the baseline characters, again, all of them are very well matched. So coming to the results, if you look at the overall survival in patients with high PD-L1 expression, so cases where we've used single agent atezolizumab, we're getting a median OS of 20 months compared to 13 months only with chemotherapy. So again, it's a good 7-month survival, which is similar to the other immunotherapy, what we've seen. If you talk about the 12-month OS, it's 64.9% versus 50.6%. We're getting a hazard ratio of 0.59. Now, if you look at the subgroup analysis, single agent atezo has done well in all the subgroups except patients with age group more than 75 or who've never been smokers. Now, yeah, coming to the PFS, again, we see a nice separation of the curves. If you talk about the median PFS, there's a benefit of around 3 months. If you look at the 12-month PFS benefit, again, statistically significant, 36.9% versus 21.6%. So we're getting a good PFS benefit as well. Coming to the responses. So if you talk about the response, it's 38.3 versus 28.6%. And median duration of response after a follow-up of around 29 to 30 months has not been evaluable in case of atezolizumab. versus it's around 6.7 months in case of patients with chemotherapy. So it's again, that is quite significant. Safety profile, obviously, single agent immunotherapy does much better than chemotherapy. Important thing to see in this slide is even with immunotherapy, we don't see much of immune-mediated side effects. And the use of steroids was used in only 10% of the patients in atezolizumab arm. Adverse effects, obviously, more with chemotherapy, things like anemia, nausea, neutropenia, constipation. More frequent with atezo were mainly pruritus, AST elevation, hypothyroidism. So to summarize, atezolizumab is promising in first-line therapy with high PD-L1. It gives a significant OS and a PFS benefit. Safety profile is definitely better. We've not seen any new unexpected side effects. And the patients treated with atezolizumab had a longer treatment exposure than patients treated with chemotherapy. Coming to the second study is IMpower 150. This is mainly non-squamous. So the first one was non-squamous as well as squamous. This is only non-squamous. So here they tried to find out whether addition of atezolizumab to the already standard of care, that is Bev plus chemotherapy in patients with non-squamous metastatic non-small cell cancer, how beneficial it was. Again, phase 3 study. So all non-squamous stage 4 non-small cell lung cancer, irrespective of the PD-L1 status. That is important. And without any kind of mutations, EGFR ALK negative. So 3 arms, atezo with chemo, that is A. B is atezo with chemo with Bev. This is the important arm, experimental arm. And C is the standard of care, that is chemo with Bev. And all of them were continued into maintenance. So this was the hypothesis that when atezolizumab ability to restore anti-cancer immunity through T-cell mediated cancers is enhanced by VEGF-mediated immunomodulatory effects. Baseline characters, again, well balanced. Important thing to note here is that liver mets was specifically highlighted in the study, and they tried to see how addition of atezolizumab has done better in patients with liver metastasis, as well as EGFR muted patients were taken in the study, that is after the first line TKI. So coming to the overall survival curves, we see significant survival benefit. If you look at the median OS, it's a difference of around 5 months. And at the end of 2 years, we're getting a hazard ratio of 0.80. So there's a 4.5 month clinically significant median OS benefit. Next slide. If you look at the responses, now addition of atezolizumab to Bev plus chemo does well irrespective of the PD-L1 status. That is what is seen, that we get a median duration of response of 11.5 months when we add the drug, compared to only 6 months in case of without immunotherapy. The important thing is that patients with high PD-L1 have done significantly better. So if you look at the second part of the slide, there's a median duration of response of 22.1 months in case of high PD-L1 level compared to only 7 months. Yeah. So again, the OS benefit also was better in patients with high PD-L1 levels, where we see a nice separation over the curve, 25.2 months compared to 15 months. Now, in case of patients with EGFR mutation, so these patients which had EGFR mutation, the sensitizing ones, that is exon 19 or L858R, who have been exposed to prior TKI therapy, around 10% of the patients were in this this group. What we saw was the curve started separating at the end of 6 months, and we get a difference of around 3 months in case of overall survival, which is again statistically significant, giving a hazard ratio of 0.59. Talk about the OS benefit in patients with sensitizing EGFR mutation, comparing arm B and arm C, again getting a good a difference, a nice separation of the curves, where this thing is 29.4 months compared to 18.1 months. So again, patients with EGFR positive who failed the first line TKI therapy have done well with atezolizumab when added to Bev and chemotherapy. Now, if you talk about the responses in patients which are EGFR positive, so the ORR increased from 42% to 71% with addition of atezolizumab to Bev plus chemotherapy. Interesting thing is 6% of the patients achieved a complete response. Now, liver metastasis. Now, patients with liver mets, all of us know that it is a negative prognostic factor. So these patients were especially highlighted in the study. And what they realized was when we add atezolizumab to the combination of Bev and chemo, we get a nice separation of the curve when you talk about the PFS. There's a difference of around 3 months, which is again quite significant. And if you look at the end of 1 year, we're getting a PFS of 34% with atezoli and Bev and chemo, and only 1.8% with only Bev and chemo. Now again, OS in patients with liver metastasis, getting a median OS of around 13.3 months compared to only 9.4 months, which is again statistically significant. And at the end of 18 months, again, it's around 34.9% versus 11.5%. So talking about the response in patients with liver mets, 60.8 versus 41%, and the median duration of response is 10.7%, 10.7 months when atezo is added to Bev plus chemo. Now, again, another interesting thing is patients with bulky disease. So what they saw was that taking patients which had bulky disease, how they've calculated is they've taken the sum of the longest diameter or number of metastatic sites. What they saw was irrespective of the burden of the disease, atezo along with Bev and chemo have done well compared to only Bev plus chemo. That is first thing. Secondly, patients with a higher burden of disease, who have a more bulky disease, they've even done better. So the bulkier the disease, better the response, better the survival when you add atezolizumab to Bev plus chemo. Let's talk about the side effects. Obviously, when you're adding 4 drugs, the side effect profile was worse. We are seeing more side effects. If you talk about the serious adverse events, it is around 44% compared to 34% in the other arm. But the results, what we've got, especially with patients with bulky disease and liver mets, I feel addition of the drugs has made a difference. So the conclusion would be it's a positive study in first-line non-squamous non-small cell lung cancer with a statistically significant and clinically meaningful improvement in both OS and PFS. This clinical benefit was observed in key subgroups where EGFR was positive and liver mets. Safety profile was pretty much expected, and patient characteristic beyond PD-L1 expression may be considered when taking immunotherapy treatment decisions for non-squamous non-small cell lung cancer. I'll skip this part. Okay. Now the last study was IMpower 130. Again, non-squamous histology. Here it is a phase 3 study where we saw with the addition of atezolizumab to chemotherapy, or chemo with or without atezo, how fairly it has done in non-squamous histology. So the goal of chemo immunotherapy combination is to create a more favorable environment to maximize the potential of immune system to eliminate cancer. 2 arms. One was atezo with nab-pacli and carbo. The reason they used nab-pacli was to basically see the steroid sparing effect of the chemotherapy regimen. So we were trying to use a chemo where steroids can be avoided to enhance the effect of immunotherapy versus the chemotherapy arm. And then maintenance of atezolizumab versus switch maintenance of pemetrexed. Now, the important thing to note here is that there was a lot of crossover in the study from arm B to arm A. So despite the protocol amendment, around 41% of the patients in the control arm crossed over to the atezolizumab arm, with a total of 59% of the patients in the control arm receiving subsequent chemoimmunotherapy. Why this is important, I'll come to this later. Now, the baseline characteristics were well balanced. We'll talk about the age, the sex, the liver mets, bone mets, etc. Investigator assessed PFS was significantly improved when you add atezolizumab to chemotherapy. So we see a median PFS of 7 months with atezo with chemo compared to 5.5 months. So the difference is 1.5 months. But if you look at the 12-month PFS, it's actually doubling. So at the landmark 12 months, the PFS was doubled from 14.1% in case of chemotherapy versus 29.1% when atezolizumab was added to chemotherapy. So PFS was significantly improved. When you talk about the OS, although we see a separation of the curve, it is not that, the separation is not that much, which could have occurred because there's a lot of crossover. So a lot of patients who've received chemotherapy went on to receive immunotherapy. But still, we are able to find a difference of around 6 months. So OS was also significantly improved in intensive treat population. And at the end of 2 years, getting around hazard ratio of 0.79. Looking at the forest plot, again, although a lot of things are favoring atezo with chemo, but because there's a lot of crossover, we're not able to comment much with this forest plot curve. Now, patients with EGFR ALK positivity were also assessed in this trial, but we don't see much PFS or OS benefit what we saw in the other trial, that is IMpower 150, when atezo was used with bev along with chemotherapy. In those patients, even EGFR positive patients had done well, but here in case of atezo and chemo, they're not doing that well. When you talk about the responses, the overall response as well as the duration of response, both were improved when atezo was added to chemotherapy. The median duration of response was around 8.4 months versus 6.1 months, which was again statistically significant. Talking about the safety profile, again, there was a higher proportion of treatment-related grade 3, grade 5 adverse events, which was again expected when you're adding immuno to chemotherapy because of the additive effect. So coming to the conclusion, IMpower 130 was a positive phase 3 study where atezo, in case of first-line non-small cell lung cancer, provided an alternative chemoimmunotherapy plus chemotherapy regimen for patients with chemotherapy-naive non-small cell lung cancer. It demonstrated statistically significant, clinically relevant OS benefit when atezo was added to chemotherapy despite a high crossover rate. It demonstrated a PFS benefit and a higher response rate. The OS and PFS benefit across all the clinical subgroups had shown benefit, but excepting the EGFR positive patients. And atezo with chemotherapy had a safety profile consistent with the adverse event associated with single agent therapy. Thank you.
Hi, thanks Dr. Taha for such a wonderful talk. The next talk would be by Dr. Shrikant Tiwari, sir. It will be on ceritinib, a frontier in the first line treatment of ALK positive non-small cell lung cancer. Sir.
Good evening, everyone. I'm sharing just my slide. Okay, so I'm starting my presentation. So this session is the session of the lung cancer, and all the speaker has speak about the different targets. So due to the development of precision oncology, in next line I'm going to discuss about what are the role of ALK inhibitors in ALK positive NSCLC patients. So we know a few years before we assumed that the NSCLC is one group of disease. Okay, but thanks to the development of this molecular biology as well as the genetic biology, now NSCLC is categorized as a heterogeneous set of disease, and each sets of disease is defined by different oncogenic drivers. The study was done on metastatic adenocarcinoma variety of NSCLC, and 5,262 patients were taken by data taken from this MSK impact as well as the Foundation 1 panel. And what they have seen that the potential X-enabled driver mutation were identified in 87% of those NCLC who are having adenocarcinoma variant, and around 64% of squamous variety of NSCLC patients. These are the different actionable mutations. Presents the most common one is the EGFR, is the most popular, we know, and the incidence is also very high. The KRAS, BRAF, ELK fusion, ROS1 fusion, RET fusion, MET amplifications, MET exon 14 skipping mutations. So the variety of the different actionable mutations are seen in variety of NSCLC patients. The molecular techniques to test these oncogenic drivers are different. It can be the PCR testing, which can be DNA or RNA based, the NGS testing, which is also DNA or RNA based, the IHC and the flow cytometry. And for this, all these different testing technology, molecular testing technology, the target analysis is different. For example, for FIS, we analyze the chromosomes. For PCR and NGS, we analyze the DNA and RNA. For IHC, we see the protein expression, and for the flow cytometry, we see the antigenic expression over the cells. The multiple genetic testings require a large volume. We know that in metastatic settings, the tissue is an important asset for the patients. And if we go for the separate testing for the separate oncogenic drivers, then it will leads to the loss of tissue, which is an important asset for the patient at this stage. So the current practice is not sustainable for the laboratory, and it is confusing for both the physician as well as the regulator. So what we are doing now, we are moving for one patient, if the patient is one multi-gen testings, and there is a need to shift to the universal testing platforms. Examples, the next generation sequencing testing, where most of the actionable mutation testing can be done in one go, and the tissue can be preserved, and less of tissue can be wasted. The guidelines, what are the guidelines recommendation for the testing of molecular biomarkers? Both this NCCN guideline as well as the ESCO guidelines say the same things. The NCCN guidelines recommend the broad molecular profiling for the established as well as the emerging biomarkers, and the ESMO guidelines also recommend the multiplex testing for the established as well as the emerging biomarkers. So what are the established and emerging biomarkers? We'll see. So this is the detail of this recommendations. The NCCN panel recommend that it considered that the broad molecular profiling is the key component for the improvement of the care of the patients who present in advanced and metastatic NSCLC. It strongly advised using broad molecular profiling to identify the rare driver mutation for which effective drugs are available. If the drugs are not available, then also the patients should be counseled to participate in the clinical trial. It is highly recommended. The recommends that the biomarker testing to be done as a part of broad molecular profiling to minimize the tissue wastage. The recommended testing according to NCCN is at least EGFR, KRAS, BRAF, ELK, MET exon 14 skipping mutations, the RET, ROS1, as well as the NTRK 1, 2, and 3. It also recommends the PDL1 testing along with this other testing, and to identify the rare driver mutation for which the therapy is available. It also recommends testing for MET amplification and ERBB2 and the tumor mutation part. The ESMO also guideline also say the same things. Other molecular testing recommends the NGS is the preferred over the sequential single gene testing to identify the other treatment options beyond the EGFR, ELK, and ROS1. For example, this BRAF, RET, and ERBB2. So the completion of testing within 10 to 14 working days of biopsy is recommended. So these are the whole recommendations how we should proceed for this molecular testing in metastatic NSCLC patients. There are certain benefits as well as the certain challenges also there when we are going for this multiplex testings. The benefit of this NGS testing is that it is reliable in detecting the known standard of care mutations with good sensitivity and specificity. It accurately identify up to 3 times more clinically actionable alteration compared with the current diagnostic test. The NGS testing panel may provide data on all known mutations and allowing access to the targeted treatment in later line of therapy also. routine nationwide molecular profiling considers is feasible if you are going to do, if the rule is there that every advanced NSCLC patients should go for this NGS testing, and the acceptable turnaround time is obtained in obtaining analysis results. So these are the benefits, but there are certain challenges also. The cost is an important issue, because the advanced techniques needs a lot of investment, and in the country like India, it is an important issue. The technical challenges is another important, because it's not very much popular, and most of the labs are not well equipped with the techniques to study and accurately reporting this NGS. So the technical challenges is an important. The accessibility issue is important for the patients, and many patients who live in the smaller towns or remote area. It is a problem to the accessibility for this NGS testing. The potential, there is chances of potential false positive result, and turnaround times, because in advanced NSCLC patients, many times the patients, the performance status when he first time present in the hospital or clinics are not very good. So and NGS and any other multiplex testing required at least 2-week time. So the turnaround time is also very important. If it can be cut down to 1 week or 5 days, definitely it will be beneficial to, for the patients in the later part. This is the next generation sequencing test. It can be DNA based and RNA based. The Novartis has provided some coupon for the financial benefit for the patients, where they can do this testing on the discounted basis. This is the NSCLC molecular classifications from EGFR to ELK, BRAF, ROS. I'm not going in detail because all the previous speakers has also shown this slide. The important aspects what I am going to discuss is the ELK rearrangement in advanced NSCLC patients. And it is seen that the incidence of this ELK rearrangement is seen in up to 7% of patients. Most patients who has ELK rearrangement NSCLC, they are usually young, they are usually never a smoker or have history of light smoking, and they usually present with the brain mets. There is a 30% chance that the ELK positive patients present with the brain mets. Now the trial, which is ASCENT-4 trials, it was a randomized phase 3 trials on the basis of which this serotinib was established as the first line therapy in ELK positive advanced NSCLC patients. The trial schema is it is a 2-arm study. Randomization was done 1:1, and after inclusion criteria, the patient were stratified according to the performance status, whether the brain mets is present or not, and patient has taken prior neoadjuvant or adjuvant chemotherapy or not. One arm was
sorry for intervening. You have 4 minutes left to conclude.
Okay. So in serotinib was 750 milligram once daily, and in another one, the chemotherapy arm was the pemetrexed cisplatin or pemetrexed carboplatin. The crossover was allowed from the chemotherapy arm in this study. And this is the median PFS. This is the Kaplan-Meier curve showing the median PFS. And if you see the median PFS, in the median PFS in serotinib arm was almost double to that of the chemotherapy arm. In chemotherapy arm, it was it is around 8.1 months, where in serotinib arm it is 16.6 months. So it is more than double. The overall response rate is around 72.5%. The duration of response is around 24 months, and 24-month overall survival rate was around 70%. So if patients put on upfront serotinib, it is seen that the risk, there is 45% risk of risk reduction of the disease progression or death versus chemotherapy. In Asian patients, the data is almost similar or even much better. The median PFS is around 26 months, whereas in chemotherapy arm is 10 months. So almost 3 times better PFS in serotinib arm compared to the chemotherapy arm. And there is 34% reduction in the risk of disease progression and death seen. Another study was the Asian ASCENT-8 study, which has also included the Asian patients in the study. After the inclusion criteria, the randomization was stratified whether the brain mets are present or absent, and the prior treatment, whether the patient has taken prior first-line treatment with the crizotinib or not. There was 3 arms in the study. All 3 arms are the serotinib arms with the different dosing. The serotinib 450 milligram with low fat meal, 600 milligram with low fat meal, and 750 milligram with low fat meal. The primary endpoint of the study was to see the steady state pharmacokinetics. The secondary endpoint was to see the overall response rate and the duration of response. And if you see this three KM curve, one is the one A is for the duration of response, the B is the PFS, and C is the overall survival. If you see the 450 milligram or the 450 milligram serotinib arm do much better in compared to the 600 or 750 milligram in the form of whether the duration of response or PFS or overall survival. So the overall response rate in 450 milligram was around 82.8%, in 600 milligram 78%, and in 750 milligram it is 76%. There is no much difference. But if you see the duration of response at 24 months, in 450 milligram it is 68.2 months versus 44.9 months versus 20.3 months. So if you compare the duration of response at 2 years, the 450 milligram has almost 3 times better duration of response. The median PFS is not reached in 450 milligram, whereas in 600 milligram it was 21.9 months, and in 750 milligram it is 8.2 months. So the 450 milligram feed arm had numerically higher overall response rate, median duration of response, 24-month duration of response, median PFS, and 24-month median PFS. There is the 36-month overall response rate was around 93.1% in 450 milligram versus only 70% in 750 milligram. The important clinical features in L-positive patients, what I have already discussed, in 30% of patients usually present with the de novo brain mets, whereas in 70% of patients have no brain mets at the time of presentation. The site of mets in ALK inhibitors who have not taken any prior anti-ALK therapy, brain mets is seen in 31 to 40% patients, 75 to 99% patients saw lung mets. Similarly, the bone and liver mets around 30 to 40% of patients. Whereas if you see the pattern of metastasis in those patients who have taken first-line ALK inhibitors, the chances of brain mets is much higher. It is 60 to 71%. So the CNS was the primary site of relapse in almost 50% of all cases who progress on crizotinib. So the next generation ALK inhibitors with increased blood-brain barrier penetration may be of higher value if you are using as first-line therapy as ALK TKI in ALK-positive NSCLC cases. This is the median PFS according to ASCENT-4 trial in patients with and without brain mets. If patient is having no brain mets, the median PFS is almost 3 times higher than chemotherapy arm. And in those patients who are having front brain mets, the median PFS is almost double to that of the chemotherapy arm. The intracranial response rate, serotinib arm, the intracranial response rate was around 72.7%, whereas in chemotherapy arm, it was 27.3%. So the intracranial response rate was around 45% more in serotinib arm compared to the chemotherapy. This is
Sorry
again
for intervening. Need to conclude, please.
Just 3-4 slides. So there is a original article which compared the efficacy of first-line serotinib and crizotinib, although it was not head-to-head trial, but it was the indirect comparison with external control. And what this indirect comparison says, yes. The PFS, if you see the PFS in profile 1014 trials, the median PFS was 10.9 months in versus 7 months in chemotherapy arm. The PFS at 18 months is 31% versus 5%, whereas in ASCENT-4 trial the PFS is 16.6 versus 8.1, and PFS at 18 months is 50% versus 23 months. The overall survival again is much in favor of this serotinib arm. Safety profile, the serotinib significantly improved the quality of life and significantly prolonged the time to deterioration for the lung cancer specific symptoms compared to the chemotherapy. It is well tolerable drugs. The most of the adverse effects are related to the GI toxicity and alteration in some liver enzyme level, but most of the adverse effects are in the grade 1 or grade 2 category. Rarely patients develop grade 3 or grade 4 GI adverse effects. These are the options which are available as a first line therapy if patient is having L positive NSCLC. The ceritinib, crizotinib, alectinib, brigatinib, and lorlatinib. This is the temporal profile how this ALK inhibitors has been developed. Now we have 3 generations of ALK inhibitors. The first generation is the crizotinib, second generation ceritinib, alectinib, and brigatinib, and third generation is lorlatinib. So I'm going to the conclusion. This is the cost-effective sequencing of ALK inhibitors in NSCLC patient, how we can sequence, because now we have 3 generations of ALK inhibitors are available. So this is the how we can sequence to have better PFS and prolonged PFS in the patients. So point, what should be considered as a clinician when we are using ALK inhibitor in the first line setting? We have to see what are the efficacy of the drug in the first line setting, whether the brain mets are present at the baseline or not. If the brain mets are present, whether the brain mets are absent or not. How much the symptomatic is the patient, and is there any second line options are available if there is progress on the first line setting. So in conclusion, according to the ASCENT-4 trials, the ceritinib saw a significant improvement in the PFS as well as the numerical improvement in the OS. The PFS benefit was also seen regardless whether the brain mets is present or not, absent. GI adverse effects were, most of the adverse effects are well manageable. Grade 3-4 adverse effects are very less, and the efficacy and safety of ceritinib are well established in ASCENT patients also. Thank you. Thank you.
Thank you, sir, for that wonderful talk. So the last but not the least talk of the evening is by Dr. Deepak Dapkara, sir. He's the Senior Consultant and Head Medical Oncology at CHL Hospital, Indore. Dr. Dapkara would be talking on making critical decisions in treatment of EGFR mutated non-small cell lung cancer. Deepak Dapkara, sir, the stage is yours.
Okay, thank you, Akash. So can someone share my slides? So this discussion is about EGFR targeted therapy. We all know it started with gefitinib, barlotinib, and these first generation TKI, they were better as compared to chemotherapy. And later other molecules came after arlotinib, this dacomitinib, afatinib, and osimertinib. Next slide. So we know the lung cancer is the most common cause of the most common cancer in the world, and it is the most common cause of mortality due to cancer. Next. In both sexes combined, lung cancer is the most commonly diagnosed cancer. About 11.6% of people cases, and the leading cause of cancer. Next. And these are the parameters which determine the choice of first-line treatment in advanced EGFR mutated lung cancer. Progression-free survival, overall response rate, presence of brain metastasis, safety, toxicity, quality of life, and patient receiving subsequent therapy upon progression. Next. So osimertinib provided unprecedented improvement in PFS in the FLORA trial. So these are various studies of various drugs. Gefitinib PFS of 9.5 months, arlotinib 13.1 months, afatinib 11 months, dacomitinib 14 months, and osimertinib 18.9 months. Next. And in progression-free survival, these are studies, different studies like afatinib versus gefitinib, 12 months, stable brain metastasis patients are included in this. In dacomitinib study, brain mets patients were excluded, and dacomitinib showed a better PFS as compared to gefitinib. And in the FLORA trial, these curves were separate from the beginning, and stable brain metastasis patients were also included in this study, and cross-trial comparison without head-to-head comparative study. So this next slide. Early separation of PFS curves is shown by osimertinib only. Next. These are overall response rate with different molecules. Afatinib overall response rate of 70%, gefitinib 56%, and afatinib response rate was better as compared to gefitinib. Disease control rate 91% versus 81%. Duration of disease control 12.7 months versus 11.1 months. And in the Archer trial, dacomitinib versus gefitinib, the median duration of response was 14.8 months versus 8.3 months. And Flora trial, response rate of 80% versus 76% with gefitinib, and complete response rate of 3% versus 1%, partial response of 77% versus 74%, and duration of response 17.2 months versus 8.5, so nearly double. Next, osimertinib has shown the highest response rate and the median duration of response. Next. So this is the overall survival data. Median survival with osimertinib 38.6 months versus 31.8 months with gefitinib. So this is the first study which has shown comparison between two EGFR TKI, gefitinib versus dacomitinib, and gefitinib versus osimertinib, which has shown a survival difference of about 7 months. There is another study, gefitinib versus dacomitinib, in which dacomitinib has shown a survival difference of few months versus gefitinib. Next slide. And median overall survival of more than 3 months. This is a Lux Lung trial and the Archer 1050 trial. In this, afatinib failed to show the improvement in overall survival versus gefitinib. And in Archer trial, overall response rate was not statistically significant, and hence formal statistical hypothesis testing for OS cannot be done. Next. These are guidelines. So all these guidelines, NCCN guidelines, ESMO guidelines, Canadian guidelines, they mention osimertinib as the first line treatment in EGFR mutated lung cancer. Next. And 28% of patients with on osimertinib, they were still receiving osimertinib at 3 years, and 28% of the patients, 22% versus 5% of patients still on treatment at the data cutoff. Next. And osimertinib demonstrated a superior systemic PFS benefit regardless of the CNS disease status. This is the left side graph is for patients with known or treated CNS metastasis. Median PFS of 15.2 months versus 9.6 months. And patients without brain metastasis also, they had PFS benefit of 19.1 months versus 10.9 months. Next. Intracranial CNS progression, median CNS progression not reached versus 13.9 months, with the hazard ratio of 0.48. Next. So intracranial or CNS response was not assessed in the Lux Lung trial, and patients with brain metastasis were excluded from the Archer dacomitinib study. Next. Safety, grade 3, grade 4 adverse events with dacomitinib reported in 63% patients. Grade 3 or 4 adverse events with afatinib were reported in 31% patients. And grade 3 or 4 adverse events with osimertinib were reported in 18%. So among these, dacomitinib, afatinib, osimertinib has the best safety profile. Next. Grade 3 and grade 4 second and third generation EGFR TKI toxicity. In Lux Lung trial, skin toxicity 9%, paronychia 2%, diarrhea 13%. In Archer study of dacomitinib, 14% skin toxicity, grade 3 or 4, 7% paronychia, and 8% grade 3-4 diarrhea. In Flora study, the toxicity is very, very less. Grade 3-4 skin toxicity in 1% patients, paronychia in 1%, and diarrhea in 2% patients only. Next. And dose reduction in Lux Lung trial, adverse events leading to dose reduction were more frequent in patients receiving afatinib compared to gefitinib, 41% versus 1.9%. In Archer trial, 66% versus 8%. In Flora study, 4% versus 5%. So all these, they show that the toxicity profile of osimertinib is much favorable as compared to dacomitinib or afatinib. Next. Quality of life, it was much, it is already discussed in the previous 2-3 slides. Quality of life is much better in patients who are taking osimertinib as compared to those who are taking afatinib or dacomitinib. Next. And 1/3 of all EGFR mutated patients treated with first and second generation TKI are unable to receive second line osimertinib. So as shown in this picture, 10 patients who are EGFR mutated mutation positive at baseline and who start gefitinib, erlotinib, or afatinib as a first line treatment. About 73 to 77% of EGFR patients receive second line treatment. 30% patients, about 30% patients, they die during the first line treatment, or they were able to receive only palliative care. They did not receive the second line drug. And 60 to 76% patients can receive a valid T790 test result. So there are various reasons. One, the patient dies during the first line treatment. Second, patient goes for palliative care. He's in such sick condition that you are not able to test. Third is about the 60 to 70% patients, they receive a valid T790M result. Other patients, about 30 to 40% patients, they do not have a T790 result. And at baseline, you do not know which patient on gefitinib or erlotinib will have a T790M mutation at progression. Next. And access to second line treatment. In IPASS study, 76% patients had second line treatment. In other studies, 48%, 72%, 88%. So approximately 1/3 patient, 20 to 30% of patients, they do not have access to second line treatment. Next. And real world evidence of T790 mutation after afatinib. In a Japanese study, 43% of 37 patients acquired T790M after first line afatinib. And in another study, 48% of the 42 patients who were rebiopsied after afatinib failure, they had acquired T790M. And in another Taiwan study of 28 afatinib treated patients, T790M was identified in 32% patients. Next. So less than 50% patients put on afatinib acquired T790M. Next.
Sir, sorry to bother, but you need to conclude, sir.
Okay. So sequencing of treatment, starting with first generation TKI, about 30% patients will not be getting second line treatment, and the best sequence for EGFR mutated patients is first line osimertinib. We have seen with the in the previous slide the gefitinib versus osimertinib, there was a 7-month survival difference, 38-month survival, overall survival, which is not seen with other TKI. Thank you. Thank you. So,
hello.
my talk is over.
Thank you, Deepak sir. It was a wonderful talk. It has been a long evening. I'd like to thank everybody for participating in this wonderful academic feast. We'll meet tomorrow again at 6:30 p.m. with a fresh set of agenda, and we hope that we'll have a lovely evening tomorrow too. Thank you very much. Thanks the Horizon team for such a wonderful support. Thank you. Thank you.
Good night.
Thank you, everyone, and look forward for your participation tomorrow again. Please log in by 6:30 p.m. Thank you, everyone.